Welcome to our deep dive into embryology of neurology. Today, we'll explore neural development, starting right from the very beginnings of the nervous system. It all begins with the notochord, a rod-like structure that serves as a kind of blueprint for the spine. The notochord will later contribute to the nucleus pulposus. That's the soft, gel-like center of your intervertebral discs, the little cushions between your vertebrae. But for now, its main job is to tell the ectoderm, the outer layer of the embryo, to start forming the neuroectoderm, which thickens into what we call the neural plate. The neural plate is like a launch pad. It gives rise to two critical structures: the neural tube, which will eventually become your central nervous system, and the neural crest cells, which will go on to form parts of the peripheral nervous system, among other things. As the neural tube develops, its lateral walls differentiate into two key plates: the alar plate on the dorsal or back side, and the basal plate on the ventral or front side. The alar plate is mostly sensory in function, receiving input from the body. Its formation is guided by proteins called bone morphogenetic proteins, or BMPs. On the other hand, the basal plate is motor, sending signals from your brain and spinal cord out to muscles. This plate is influenced by a protein known as Sonic Hedgehog, abbreviated SHH. Yes, like the video game character, but here it's all about development. The overall segmentation of the neural tube, including the cranial to caudal or head to tail differentiation, is controlled by homeobox genes, often shortened to HOX genes. When these genes are mutated, it can result in developmental anomalies like syndactyly, which is fused fingers or toes, or hypospadias, a malformation of the urinary and genital tract in males. Next, let's talk about regionalization, which is how the neural tube forms distinct parts of the brain. The very first part to develop is the telencephalon, followed by the diencephalon. After that, the rest of the brain regions develop and are often arranged alphabetically: mesencephalon, metencephalon, and myelencephalon. During early brain development, we start with three primary vesicles. Think of them as the first little bubbles forming the brain: the forebrain or prosencephalon, the midbrain or mesencephalon, and the hindbrain or rhombencephalon. These primary vesicles then divide further into 5 secondary vesicles, each of which has distinct adult derivatives and fluid-filled cavities. For the forebrain, the telencephalon will give rise to the cerebral hemispheres, which control everything from thought to movement, and the basal ganglia, which help coordinate movement. The diencephalon forms the thalamus, the brain's relay station, the hypothalamus, which regulates hormones and basic drives, and even the retina, which is part of the eye. The midbrain, which is still called the mesencephalon, forms part of the brainstem, maintaining functions like eye movement and auditory processing. Its cavity becomes the cerebral aqueduct, a narrow channel that connects brain fluid pathways. The hindbrain, or rhombencephalon, divides into the metencephalon and myelencephalon. The metencephalon develops into the pons and cerebellum, which are crucial for coordination and balance. The myelencephalon becomes the medulla oblongata, controlling vital functions like breathing and heart rate. Finally, the spinal cord develops from the lower portion of the neural tube, completing the core structure of the central nervous system. Now let's talk about origins. Most central nervous system neurons and glial cells, that's supportive cells like astrocytes, oligodendrocytes, and ependymal cells, come from the neuroepithelium of the neural tube. Meanwhile, the neural crest cells migrate to form peripheral nervous system neurons, such as dorsal root ganglia and autonomic ganglia, including sympathetic, parasympathetic, and enteric ganglia. These cells also give rise to Schwann cells and satellite cells, which support neurons in the peripheral nervous system, as well as the adrenal medulla, which releases adrenaline. Interestingly, the microglia, the immune cells of the central nervous system, come from mesoderm, not the neural tube or neural crest. They act like specialized macrophages, cleaning up debris and protecting neurons. Now, let's move on to neural tube defects, or NTDs. These occur when the neural tube, which normally forms the brain and spinal cord, fails to close completely by the 4th week of development. This can happen if the mother has a folate deficiency or if she is exposed to certain teratogens, substances that interfere with development, such as valproate or carbamazepine, during pregnancy. Doctors can diagnose these defects using ultrasound imaging or by measuring maternal serum alpha-fetoprotein, abbreviated AFP, and sometimes amniotic fluid acetylcholinesterase, known as VE, especially if the defect is open. Let's start with spinal dysraphism, which affects the spine. The first type is spina bifida occulta, which is a closed neural tube defect. Here, the caudal, or tail end, neural tube fails to close, but there's no herniation of tissue. The protective dura, which is the outer membrane covering the spinal cord, remains intact. This usually occurs at lower vertebral levels and can often be identified by a tuft of hair or a skin dimple over the affected vertebra. Next is meningocele, an open neural tube defect. In this condition, the meninges, the membrane surrounding the spinal cord, herniate through the bony defect, but the neural tissue itself stays in place. Then we have myelomeningocele, which is more severe. This is also an open defect, but now both the meninges and neural tissue, like parts of the cauda equina, actually protrude through the spinal opening. The most severe form is myeloschisis, where the neural tissue is exposed, unfused, and there's no covering of skin or meninges. Moving up to the head, we encounter cranial dysraphism. One major example is anencephaly, an open neural tube defect caused by failure of the rostral, or head end, neuropore to close. In anencephaly, the forebrain does not develop and the calvarium, or skull, remains open. This condition often presents with polyhydramnios, meaning excess amniotic fluid, because the fetus can't swallow properly due to lack of neural control. Depending on the type of defect, you might see different changes in the skin and surrounding tissues. In spina bifida occulta, the skin is usually normal, though a tuft of hair or skin dimple may mark the spot. In meningocele, a skin defect or thinning may be present. Myelomeningocele features thin or absent skin, herniated meninges, and exposed neural tissue. Myeloschisis has fully exposed neural tissue without any skin or meningeal covering. Brain malformations can also occur and are often incompatible with life after birth, and survivors may be profoundly disabled. One notable brain malformation is holoprosencephaly, which happens when the forebrain, or prosencephalon, fails to divide into 2 cerebral hemispheres. This is a developmental field defect that typically occurs between the 3rd and 4th weeks of development. It's associated with mutations in the sonic hedgehog gene, SHH, and can also appear in Patau syndrome, which is trisomy 13, or in fetal alcohol syndrome. Holoprosencephaly often presents with midline facial defects. You might see a single ventricle in the brain, fused basal ganglia, cleft lip or palate, closely spaced eyes called hypothalamus, or even cyclopia, where there's a single eye, and proboscis, a tubular nasal structure. There's also a risk for pituitary dysfunction, such as diabetes insipidus. Another serious malformation is lissencephaly, literally meaning smooth brain. Here, neurons fail to migrate properly during development, resulting in a brain surface without the normal folds or gyri and grooves or sulci. Patients often present with difficulty swallowing, seizures, a small head known as microcephaly, and facial anomalies. Now let's move on to posterior fossa malformations. These are structural abnormalities that affect the cerebellum and surrounding areas at the back of the brain. The first one is Chiari type 1 malformation. In this condition, the cerebellar tonsils, that's one specific part of the cerebellum, are displaced downward through the foramen magnum, which is the large opening at the base of the skull. Chiari type 1 is often asymptomatic in childhood, so children may seem perfectly fine. But in adulthood, symptoms usually appear, including headaches and cerebellar signs, like problems with balance or coordination. This condition is often associated with Syringomyelia, which is a cavity inside the spinal cord that we'll cover in just a moment. The second, more severe form is Chiari type 2 malformation. Here, not just the cerebellar tonsils, but also the cerebellar vermis, the central part of the cerebellum, and the medulla, part of the brainstem, are displaced downward through the foramen magnum. Since two structures are herniating here, it's easy to remember this is type 2. This causes non-communicating hydrocephalus, which means fluid builds up in the brain because the normal flow of cerebrospinal fluid is blocked. Babies with Chiari type 2 often present early in life with serious symptoms such as difficulty swallowing, noisy breathing called stridor, pauses in breathing called apnea, and weakness in the limbs. It's almost always associated with a myelomeninges seal, usually in the lower back or lumbosacral region. Another major malformation is the Dandy Walker malformation. In this condition, the cerebellar vermis fails to develop, which leads to a large cystic enlargement of the fourth ventricle. This cyst expands and fills the posterior fossa, the space at the back of the skull. Like Chiari type 2, it is often associated with non-communicating hydrocephalus and spina bifida. Now, let's shift to Syringomyelia, a condition commonly linked to Chiari type 1. The word syrinx comes from Greek, meaning tube, just like a syringe. A syrinx is a fluid-filled cavity inside the spinal cord that is lined by scar-like tissue called gliosis. The key problem here is that the syrinx tends to compress the fibers that cross in the anterior white commissure, which are part of the lateral spinothalamic tract. This tract carries pain and temperature sensations. As a result, patients develop a classic cape-like pattern of sensory loss over the shoulders and arms. Imagine wearing a cape that blocks your ability to feel pain and temperature. As the syrinx expands, it can also damage the anterior horn cells of the spinal cord, leading to lower motor neuron signs, such as muscle weakness, atrophy, and fasciculations. Most syrinxes occur between the second cervical vertebra, C2, and the ninth thoracic vertebra, T9. They are usually associated with Chiari type 1 malformation, but can also result from infections, trauma, or tumors. Welcome back. Now, let's talk about anatomy and physiology of neurology. Cells of the nervous system. We've got two big groups here, neurons and non-neuronal cells, which are also called glial cells. Neurons are permanent, signal-transmitting cells of the nervous system. They're made up of dendrites, which receive input, cell bodies, and axons, which send output. Dendrites and cell bodies can be seen on Nissl staining because it stains rough endoplasmic reticulum. Axons don't have rough endoplasmic reticulum, so they don't show up. Neuron markers include neurofilament protein and synaptophysin. Central nervous system glial cells come from neuroectoderm, except for microglia, which derive from mesoderm. Peripheral nervous system glial cells come from neural crest ectoderm. Myelin is a multi-layer wrapping of electrical insulation formed around axons. It increases conduction velocity of transmitted signals by saltatory conduction of action potentials at nodes of Ranvier, where sodium channel density is high. Now let's break down the central nervous system glial cells. Astrocytes give physical support, repair, remove excess neurotransmitters, form part of the blood-brain barrier, and act as a glycogen fuel reserve buffer. They are GFAP positive. They're the largest and most abundant glial cells in the CNS. After neural injury, they respond with reactive gliosis. Oligodendrocytes myelinate axons in the central nervous system, including cranial nerve 2. They have a fried egg appearance on histology. Think oligodendrocytes. Each one myelinates many axons, about 30. They're the predominant glial cell in white matter. They're the ones that get injured in multiple sclerosis, leukodystrophies, and progressive multifocal leukoencephalopathy. Ependymal cells are ciliated, simple columnar glial cells lining the ventricles and the central canal of the spinal cord. Their apical surfaces have cilia, which circulate cerebrospinal fluid, and microvilli, which help absorb it. Specialized ependymal cells in the choroid plexus produce cerebrospinal fluid. Microglia activate in response to tissue damage, releasing inflammatory mediators like nitric oxide and glutamate. They don't show up on Nissl stain. They're phagocytic scavenger cells of the CNS. In HIV infection, microglia can fuse to form multinucleated giant cells, which are seen in HIV-associated dementia. Now for peripheral nervous system glial cells. Satellite cells surround neuronal cell bodies in ganglia. They play a supportive role, kind of like astrocytes do in the CNS. Schwann cells myelinate axons in the peripheral nervous system, including cranial nerves 3 through 12. They are S100 positive. Each Schwann cell myelinates a single axon, easy to remember with Schwann cell, one axon. They're the ones injured in Guillain-Barré syndrome. All right, let's talk about the neuron action potential. So at rest, the membrane is sitting at the resting potential, and here the membrane is way more permeable to potassium than sodium. Both the voltage-gated sodium and potassium channels are closed. Now, once the membrane gets depolarized, the sodium activation gates swing open and sodium rushes in. That's the upstroke. Then, at the peak potential, the sodium inactivation gate shuts, stopping any more sodium from coming in, while at the same time the potassium activation gate opens, letting potassium flow out. That's what drives repolarization. But potassium gates are a little slow to close, so too much potassium leaves the cell. That's hyperpolarization, that little dip below resting potential. Eventually, the sodium channels reset, and the sodium-potassium pump works to restore the normal ion balance. Now, sensory receptors, let's break them down. Free nerve endings first. These use A delta fibers, which are fast and myelinated, and C fibers, which are slow and unmyelinated. Think of it like this. A delta plane is fast, but a taxi is slow. They're basically everywhere in the body except cartilage and the eye lens, and they're especially common in the skin. They detect pain and temperature. Next are the Meissner corpuscles. These have large, myelinated fibers that adapt quickly. You'll find them in glabrous, hairless skin, like palms, soles, and lips. They're great for sensing light touch, fine detail, low-frequency vibration, and even skin indentation. Then we've got Pacinian corpuscles, also large, myelinated, and fast-adapting. These sit deeper in the skin, ligaments, and joints. They specialize in high-frequency vibration and pressure. Easy way to remember, pressure cooker, Pacinian. Merkel discs come next. They're large, myelinated, but adapt slowly. They live in the fingertips and the superficial layers of skin. These are all about pressure and deep static touch, so shapes, edges, and steady contact. Finally, Ruffini corpuscles. They're large, myelinated fibers that sit intertwined with collagen bundles, and they adapt slowly. Found in fingertips and joints, and they respond to stretch and changes in joint angle. All right, let's start with the peripheral nerve. Think of it like electrical wiring wrapped in different protective layers. The endoneurium is the thin, supportive connective tissue that ensheathes and supports individual myelinated nerve fibers. This delicate layer may be affected in Guillain-Barré syndrome. Next is the perineurium, which forms the blood-nerve permeability barrier. It surrounds a fascicle of nerve fibers, basically grouping them together and controlling what can pass in and out. On the outside, there's the epineurium, a dense connective tissue layer that surrounds the entire nerve, including all fascicles and blood vessels, holding everything firmly in place. A quick memory trick: endo means inner, peri means around, and api means outer. Now let's look at the neuronal response to axonal injury. First comes chromatolysis. Here, Nissl substance disperses throughout the cytoplasm, so the rough ER is no longer visible on staining. The neuronal cell body reacts by increasing protein synthesis in an effort to repair the damaged axon. This is accompanied by round cellular swelling and displacement of the nucleus to the periphery. Then comes axonal retraction. The proximal axon segment, the part closest to the cell body, retracts and sprouts new protrusions. These new growths reach out toward other neurons for potential reinnervation. In the PNS, Schwann cells create a tract that helps guide axonal regeneration. Meanwhile, the distal axon segment undergoes Wallerian degeneration. The distal axon and its associated myelin sheath break down, while macrophages move in to clear away the debris. In the CNS, however, the picture is different. Myelin debris tends to persist, and reactive gliosis prevents axonal regeneration. That's why recovery is limited in the CNS. But in the PNS, axonal regeneration is facilitated thanks to Schwann cells. Now let's shift into neurotransmitter changes with disease. Acetylcholine. It's synthesized in the basal nucleus of Maynard in the forebrain. Levels go down in Alzheimer's disease and in Huntington's disease, but they go up in Parkinson's disease. Dopamine, produced in the ventral tegmentum and the substantia nigra pars compacta, SNC, of the midbrain. In depression, dopamine decreases. In schizophrenia, it increases. In Huntington's disease, it also goes up. And in Parkinson's disease, dopamine goes down. GABA, synthesized in the nucleus accumbens of the basal ganglia. It decreases in both anxiety and Huntington's disease. Norepinephrine, made in the locus ceruleus of the pons. Levels rise in anxiety but fall in depression. Serotonin, produced in the raphe nuclei of the brainstem. It decreases in both anxiety and depression and also decreases in Parkinson's disease. Meninges, the protective layers around the brain and spinal cord. There are 3 of them, and they come from both neural crest and mesoderm. First, the dura mater. This is the thick, outer layer sitting closest to the skull. Next, the arachnoid mater. That's the middle layer with its classic web-like connections. And finally, the pia mater, the thin, fibrous inner layer that hugs the brain and spinal cord tightly. Between the arachnoid and pia lies the subarachnoid space, and that's where CSF flows. Now, there's also the epidural space, a potential space between the dura mater and the skull, or vertebral column. It contains fat and blood vessels, and it's the site of blood collection when the middle meningeal artery is injured. Next up, the blood-brain barrier, the BBB. Its whole job is to prevent circulating substances like bacteria or drugs from slipping into the CSF and CNS. It's formed by 4 key structures. Tight junctions between non-fenestrated capillary endothelial cells. A basement membrane. Parasites. And astrocyte foot processes. Now, glucose and amino acids get through, but slowly and only via carrier-mediated transport. Nonpolar and lipid-soluble substances, they zip right across by diffusion. There are also circumventricular organs, special brain areas that don't have a BBB because their capillaries are fenestrated. This allows blood molecules to affect brain function. For example, the area postrema, that's the puke center, triggers vomiting after chemotherapy. The OVLT, organum vasculosum of the lamina terminalis, has osmoreceptors. And the neurohypophysis releases neurosecretory products like ADH directly into circulation. When the BBB is disrupted, like after a stroke, you get vasogenic edema. Hyperosmolar agents, like mannitol, can also disrupt it and increase permeability to medications. Now, let's switch gears to the vomiting center. It's coordinated by the nucleus tractus solitarius, or NTS, in the medulla. The NTS gets input from multiple places. The chemoreceptor trigger zone, or CTZ, which is located in the area postrema, right at the base of the fourth ventricle. Fun trick, pronounce it pukestrema. The GI tract, via the vagus nerve. The vestibular system, and higher centers in the CNS. The CDZ and the nearby vomiting center nuclei use 5 major receptors: histamine H1, muscarinic M1, neurokinin K1, dopamine D2, and serotonin 5, HT3. That's why different antiemetics target different pathways. 5-HT3, D2, and NK1 antagonists are great for chemotherapy-induced vomiting. H1 and M1 antagonists work for motion sickness. And H1 antagonists can also help with hyperemesis gravidarum. All right, let's talk about sleep physiology. On a typical night, sleep happens in about 4 to 6 cycles, and each cycle lasts around 90 minutes. Each of these cycles is made up of 2 main stages: non-rapid eye movement sleep and rapid eye movement sleep. The interesting thing is that the duration of rapid eye movement sleep actually increases as the night goes on. The whole sleep-wake cycle is controlled by the circadian rhythm, which is regulated by the suprachiasmatic nucleus in the hypothalamus. Light is the main input for this system. The suprachiasmatic nucleus activity leads to norepinephrine release from the superior cervical ganglion, which then stimulates the pineal gland to secrete melatonin, the hormone that helps set your sleep rhythm. Now, let's move to brain activity. The electroencephalogram, better known as the EEG, shows different waveforms depending on the sleep stage. To remember them in order through the night, we say bats drink blood, that stand for beta, alpha, theta, sleep spindles, delta, and then back to beta. Here's the breakdown. When you are awake and alert, with active mental concentration and your eyes open, the EEG shows beta waves. These have the highest frequency and the lowest amplitude. When you're awake but your eyes are closed and you're relaxed, you see alpha waves. Then comes non-rapid eye movement sleep. Stage N1 makes up about 5% of sleep, it's light sleep, and the EEG shows theta waves. Stage N2 is the largest chunk of sleep, about 45%, and here you see sleep spindles and K-complexes. This is the stage where bruxism happens, which is teeth grinding. Stage N3 is about 25% of sleep, and it's the deepest stage of non-rapid eye movement sleep, also called slow-wave sleep. The EEG here shows delta waves, which are the lowest frequency but the highest amplitude. This is the stage when bedwetting, sleepwalking, and night terrors occur. Think wee and flee in N3. Then we hit rapid eye movement sleep, which also takes about 25% of the night. This stage is unique because you lose almost all muscle tone, called atonia, except in your diaphragm and your extraocular muscles. Brain oxygen use increases, and your pulse and blood pressure become variable. This is the stage where dreaming, nightmares, and sexual arousal like penile or clitoral tumescence happen. A nice way to remember is rapid eye movement equals remember dreams. Now, there's a condition called rapid eye movement sleep behavior disorder. Normally, your body is paralyzed in rapid eye movement sleep. But in this disorder, you lose that atonia. That means people act out their dreams, sometimes violently, with kicking, punching, or shouting. It's most often linked with Lewy body dementia and Parkinson's disease. A lot of things can affect sleep architecture. Alcohol, benzodiazepines, and barbiturates all decrease stage N3 and rapid eye movement sleep. Interestingly, benzodiazepines can actually be useful in treating sleepwalking and night terrors. With aging, both stage N3 and rapid eye movement sleep decrease, and older adults often fall asleep faster but wake up earlier in the morning. Depression changes the pattern too. It decreases stage N3 sleep but increases rapid eye movement sleep, shortens the rapid eye movement latency, and leads to repeated nighttime awakenings and early morning awakening, also called terminal insomnia. And finally, narcolepsy is associated with decreased rapid eye movement latency, meaning people fall into rapid eye movement sleep much faster than normal. All right, let's dive into the hypothalamus and thalamus. The hypothalamus is the master regulator that maintains homeostasis. It handles thirst and water balance, controls the release of hormones from the anterior pituitary, also called the adenohypophysis, and the posterior pituitary, also called the neurohypophysis. It also regulates hunger, the autonomic nervous system, body temperature, and sexual urges. You can remember that with the mnemonic TAN hats: thirst, adenohypophysis, neurohypophysis, hunger, autonomic nervous system, temperature, and sexual urges. The hypothalamus also has inputs from areas that are not protected by the blood-brain barrier. One of these is the organum vasculosum of the lamina terminalis, which senses changes in osmolarity. The other is the area postrema, found in the dorsal medulla, which responds to emetics. Now let's look at the individual nuclei. The lateral nucleus is the hunger center. It is stimulated by the hormone ghrelin and inhibited by leptin. If you destroy the lateral nucleus, you get anorexia and failure to thrive in infants. The way to remember is lateral injury makes you lean. The ventromedial nucleus is the satiety center. It is stimulated by leptin. If this nucleus is destroyed, such as with a craniopharyngioma, it causes hyperphagia. The way to remember is ventromedial injury makes you very massive. The anterior nucleus controls cooling and is linked to the parasympathetic system. For anterior, C for cooling. AC equals anterior cooling. The posterior nucleus controls heating and is linked to the sympathetic system. Think of the posterior nucleus as the hot pot. The suprachiasmatic nucleus regulates the circadian rhythm. You can remember that SCN is the sun-sensing nucleus. The supraoptic and paraventricular nuclei synthesize two important hormones: antidiuretic hormone, also called ADH, and oxytocin. The way to remember is SAD-POX. Supraoptic equals antidiuretic hormone. Paraventricular equals oxytocin. Antidiuretic hormone and oxytocin are carried by proteins called neurophysins down the axons to the posterior pituitary, where these hormones are stored and eventually released. Destruction of this system can cause central diabetes insipidus. The preoptic nucleus is involved in thermoregulation and sexual behavior, and it releases gonadotropin-releasing hormone, or GnRH. And if gonadotropin-releasing hormone producing neurons fail to migrate from the olfactory pit, you get Kalman syndrome. Now, moving on to the thalamus. The thalamus is the major relay center for all ascending sensory information, except the sense of smell. Let's go through the nuclei. The ventral posterolateral nucleus receives input from the spinothalamic tract and the dorsal columns, also called the medial lemniscus pathway. It carries information about vibration, pain, pressure, conscious proprioception, light touch, and temperature. Its destination is the primary somatosensory cortex in the parietal lobe. The ventral posteromedial nucleus receives input from the trigeminal and gustatory pathways. It carries sensation from the face and the sense of taste. Its destination is also the primary somatosensory cortex in the parietal lobe. The mnemonic is very pretty makeup goes on the face. The lateral geniculate nucleus receives input from cranial nerve 2, the optic chiasm, and the optic tract. It processes vision, and its destination is the primary visual cortex in the occipital lobe. The mnemonic is lateral equals light. The medial geniculate nucleus receives input from the superior olive and the inferior colliculus of the tectum. It processes hearing, and its destination is the primary auditory cortex in the temporal lobe. The mnemonic is medial equals music. Finally, the ventral anterior and ventrolateral nuclei receive input from the basal ganglia and the cerebellum. They are involved in motor control, and their destination is the motor cortices in the frontal lobe. You can remember that with Venus astronauts vow to love moving. All right, let's talk about the limbic system and the dopaminergic pathways. The limbic system is basically a collection of neural structures that are heavily involved in emotion, long-term memory, the sense of smell, behavior modulation, and autonomic nervous system function. The key parts include the hippocampus, the amygdala, the mammillary bodies, the anterior thalamic nuclei, the cingulate gyrus, and the entorhinal cortex. Together, this system is responsible for feeding, fleeing, fighting, feeling, and sex, the famous 5 Fs. Now, moving on to the dopaminergic pathways. These are commonly altered by drugs, such as antipsychotics, and in movement disorders like Parkinson's disease. The 2 pathways most closely tied to addiction behaviors are the mesocortical and mesolimbic pathways. Let's go through each one. The mesocortical pathway runs from the ventral tegmental area to the prefrontal cortex. It is mainly involved in motivation and reward. When its activity decreases, it can lead to negative symptoms like lack of motivation or flat affect. Antipsychotic drugs usually have limited effect on these negative symptoms. The mesolimbic pathway also originates in the ventral tegmental area but projects to the nucleus accumbens. Increased activity here is linked to positive symptoms, such as hallucinations or delusions. This is the primary therapeutic target of antipsychotic drugs. The nigrostriatal pathway goes from the substantia and nigra to the dorsal striatum. It controls motor function, and if its activity is disrupted, you get extrapyramidal symptoms, basically movement problems. This pathway is significantly affected both by antipsychotics and in Parkinson's disease. Finally, the tuberoinfundibular pathway runs from the hypothalamus to the pituitary gland. It regulates prolactin secretion. If its activity drops, prolactin levels increase, leading to side effects like galactorrhea or amenorrhea. This pathway is also significantly affected by antipsychotics. All right, let's go over the cerebellum. The cerebellum is all about modulating movement, helping with coordination, and keeping balance in check. It receives unconscious proprioceptive information from the spinal cord through the inferior cerebellar peduncle, and it processes that information to fine-tune body movement. Inside, the deep nuclei are arranged from lateral to medial, dentate, emboliform, globose, and fastigial, and an easy way to remember that is do not eat greasy foods. Now, functionally, the medial cerebellum, which includes the vermis, controls the axial muscles and the proximal limb muscles on both sides, basically the medial structures. The lateral cerebellum, which means the hemispheres, controls the distal limb muscles on the same side of the body, the lateral structures. When you test the cerebellum clinically, you look for issues with rapid, alternating movements like pronation and supination. You do the finger-to-nose test, the heel-to-shin test, you check the gait, and you look for intention tremor. As for inputs and outputs, proprioceptive information comes in from the spinal cord through the inferior cerebellar peduncle. The contralateral cerebral cortex sends information through the middle cerebellar peduncle. The inner ear sends balance information to the vestibular nuclei and the flocculonodular lobe. For outputs, the cerebellar cortex communicates through Purkinje cells to the deep nuclei. From there, signals leave through the superior cerebellar peduncle to reach the contralateral cerebral cortex. The medial cerebellum connects strongly with the vestibular nuclei, while the lateral cerebellum is more about fine-tuned limb control. Basal ganglia. These guys are really important when it comes to voluntary movements and adjusting posture. They basically receive cortical input and then provide negative feedback to the cortex to help modulate movement. Here's a quick way to remember. D1 receptors mean the D1 rect pathway, which is the direct pathway. The indirect pathway uses D2 receptors, so think indirect D2 equals inhibitory. Now, let's break down the structures. The striatum is made up of the putamen, which is mostly motor, and the caudate nucleus, which is more cognitive. The lentiform nucleus is the putamen plus the globus pallidus. So how do the pathways work? First, the direct excitatory pathway. Cortical input using glutamate stimulates the striatum. The striatum then releases GABA, which inhibits the internal segment of the globus pallidus, the GPI. Since the GPI is inhibited, it can't suppress the thalamus as much. The thalamus is now disinhibited, meaning activated, and that fires up motion. So the direct pathway basically facilitates movement. Gas pedal on. Next, the indirect inhibitory pathway. Again, cortical input with glutamate stimulates the striatum, and the striatum releases GABA, but this time it inhibits the external segment of the globus pallidus, the GP. When the GP is inhibited, the subthalamic nucleus, the STN, gets more active. The STN then sends glutamate to the GPI, which causes the GPI to release GABA and inhibit the thalamus. And when the thalamus is inhibited, motion is suppressed. So the indirect pathway is like the brakes. Now here's where dopamine comes in. Dopamine from the substantia nigra pars compacta, the SNC, part of the nigrostriatal pathway, plays both sides. It stimulates the direct pathway by binding to D1 receptors, and, at the same time, it inhibits the indirect pathway by binding to D2 receptors. The end result? Dopamine promotes motion. If you picture the diagram, dopamine comes in from the SNC, acting on D1 and D2 receptors. The motor cortex sends signals down, the thalamus sends them back up, and the GPI, GP, striatum, subthalamic nucleus, and substantia nigra all interact in this push and pull system. Direct pathway facilitates movement. Indirect pathway inhibits movement. And when you look at a brain slice, you'll see the caudate nucleus along the lateral ventricle, the internal capsule running down, the lentiform nucleus made of the putamen and globus pallidus, and nearby structures like the thalamus, hypothalamus, STN, SNC, amygdala, hippocampus, and mammillary body, all wired together to fine-tune motor control. All right, let's take a tour of the cerebral cortex, the wrinkled outer layer of the brain where the real magic happens. Starting at the frontal lobe, this is your decision-making and executive center. Within it, you'll find the prefrontal cortex responsible for planning, judgment, and personality. Just a little above, there's the frontal eye field, which helps control voluntary eye movements, basically letting you track and shift your gaze on command. Next, we move toward the premotor cortex, sitting just in front of the primary motor cortex. The premotor area is all about preparing and planning movements, while the primary motor cortex handles execution, sending signals to your muscles so you can move. Separating motor from sensation is the central sulcus. Right behind it, you'll find the primary somatosensory cortex, which receives all the touch, pressure, pain, and temperature information from your body. Just next door is the somatosensory association cortex, which takes that raw input and makes sense of it, like recognizing an object by touch alone. Now, sliding into the parietal lobe, this is your spatial awareness zone. Damage here can lead to neglect of one side of your body or surroundings. Swinging down to the temporal lobe, it houses the primary auditory cortex, so this is where sound is first processed. The temporal lobe is also big on memory and language. Here, you'll see Wernicke's area in the dominant hemisphere, usually the left, which is the comprehension center for language. If it's damaged, speech might sound fluent, but will lack meaning. Just a bit forward in the temporal region, we spot the limbic association area, important for emotion and memory processing. At the bottom edge, running like a boundary, is the Sylvian fissure, also called the lateral sulcus, which separates the temporal lobe from the frontal and parietal lobes. Now, moving all the way back, we get to the occipital lobe, the brain's vision hub. Right here sits the primary visual cortex, where all the raw visual signals from your eyes first land. Finally, in the frontal lobe again, we can't forget Broca's area, usually on the left side. This is the motor speech area. It lets you form words and physically speak. Damage here leaves you understanding language, but struggling to get words out. And tying it together, notice the arcuate fasciculus, a white matter tract connecting Broca's and Wernicke's areas, basically the communication highway between speech production and comprehension. Let's dive into cerebral perfusion, how the brain keeps its blood supply steady. Cerebral blood flow relies on very tight autoregulation. Basically, the brain making sure it always gets enough blood, no matter what's happening elsewhere in the body. The main driver of this regulation is the partial pressure of carbon dioxide in arterial blood. Oxygen, or partial pressure of oxygen in arterial blood, also modulates perfusion, but it really matters only in severe hypoxia, like in mountain sickness. When oxygen levels drop too low, hypoxia triggers cerebral vasodilation, which increases cerebral blood flow, but the downside is that it can also cause cerebral edema or swelling in the brain. Now, cerebral perfusion also depends on a pressure gradient. Think of it as a tug-of-war between mean arterial pressure and intracranial pressure. If blood pressure decreases or intracranial pressure increases, cerebral perfusion pressure will decrease. There's a classic clinical sign called the Cushing reflex. It shows up as a triad: hypertension, which is high blood pressure, bradycardia, which is a slow heart rate, and respiratory depression, which is slowed breathing. This reflex kicks in as a response to elevated intracranial pressure. Clinically, there's a treatment trick called therapeutic hyperventilation. When a patient hyperventilates, carbon dioxide levels in the blood drop, so partial pressure of carbon dioxide decreases. That drop causes vasoconstriction, which narrows the blood vessels. Narrower vessels reduce cerebral blood flow and lower intracranial pressure. Doctors may use this as a temporary measure to treat acute cerebral edema, like swelling after a stroke, when other interventions aren't working. Now let's break down the key formula. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. If cerebral perfusion pressure equals 0, that means there is no blood flow to the brain at all. That condition equals brain death, coma, absent brainstem reflexes, and apnea, which means no breathing. There's another oxygen point to remember. Hypoxemia, meaning low levels of oxygen in the blood, will only increase cerebral perfusion if the partial pressure of oxygen in arterial blood drops below 50 millimeters of mercury. And with carbon dioxide, cerebral perfusion pressure is directly proportional to the partial pressure of carbon dioxide in arterial blood until that partial pressure of carbon dioxide rises above 90 millimeters of mercury. Beyond that level, the effect plateaus. The homunculus, that funky little topographic map of the brain. Think of it as a distorted cartoon of your body, stretched across the motor and sensory cortex. Why distorted? Because some parts of your body, like the hands and lips, have way more nerve endings and connections, so they hog extra space on the cortex. More innervation means bigger cortical representation. All right, picture this, the motor homunculus. Starting way up top, at the midline, you've got the hip and the trunk. Then moving down, there's the knee, the shoulder, and the elbow. Slide a little further, and you reach the wrist, and then the hand. Now the hand is broken down finger by finger, little finger, ring finger, middle finger, index finger, and thumb, all laid out across the cortex. Then comes the neck, the brow, and the eyelid and eyeball area. Drop lower and you see the lips, the jaw, the tongue, and finally the swallowing muscles. Now flip over to the sensory homunculus. Again, starting at the midline with the hip, then the leg, the trunk, and the foot. After the foot, the toes show up, and even the genitals get their own little spot. Moving laterally, you'll find the neck, the head, the shoulder, the arm, the elbow, the forearm, and the wrist. Just like the motor map, the sensory one zooms into the hand, with the little finger, ring finger, middle finger, index finger, and thumb all lined up. Next comes the eye, the nose, the face, and the upper lip. Then we move inward, the intra-abdominal region, the pharynx, the lower lip, the teeth and gums, and finally the tongue. Now, blood supply. 3 big cerebral arteries feed these cortical zones. The anterior cerebral artery takes care of the anteromedial surface. The middle cerebral artery handles the lateral surface. And the posterior cerebral artery covers the posterior and inferior surfaces. Together, they keep the homunculus alive and firing. Let's talk watershed zones. Imagine borders where 2 territories meet. Cortical border zones are found between the anterior and middle cerebral arteries, and also between the posterior and middle cerebral arteries. These are the blue areas in the diagram. Internal border zones, on the other hand, sit between the superficial and deep vascular territories of the middle cerebral artery. Those are the red areas. And here's a clinical pearl. These watershed regions, they're common hotspots for brain metastases. Now, infarcts. If you've got severe hypoperfusion, meaning blood flow just isn't getting where it needs to go, you can end up with watershed infarcts. For example, an anterior cerebral artery, middle cerebral artery watershed infarct causes proximal upper extremity weakness, but spares the legs. Doctors like to call that man-in-a-barrel syndrome. Then there's the posterior cerebral artery, middle cerebral artery watershed infarct, which tends to mess with higher-order visual function. Circle of Willis. This is a ring of anastomoses, connections, that link the anterior and posterior circulations of the brain. Its whole purpose is to maintain cerebral perfusion in cases of occlusion or stenosis of the major cranial arteries. Basically, if one route is blocked, the circle gives blood another way to flow. Now let's look at the arteries that make it up. From the anterior circulation, we've got the anterior cerebral artery, ACA, the internal carotid artery, ICA, and the middle cerebral artery, MCA. From the posterior circulation, we've got the anterior communicating artery, ACUM, the posterior communicating artery, PCOM, the posterior cerebral artery, PCA, the superior cerebellar artery, SCA, the anterior inferior cerebellar artery, AICA, and the posterior inferior cerebellar artery, PICA. To break it down further, the anterior communicating artery links the 2 anterior cerebral arteries. The anterior cerebral artery runs forward along the medial surface. The middle cerebral artery branches laterally into the sylvian fissure. The posterior communicating artery connects the carotid system to the posterior cerebral artery. The posterior cerebral artery comes off the basilar system. And don't forget the superior cerebellar artery, the anterior inferior cerebellar artery, and the posterior inferior cerebellar artery, all branching off to feed the cerebellum. If you flip to an inferior view, you'll see the optic chiasm sitting in the middle, the internal carotid arteries on either side, with small branches like the lenticulostriate arteries and the anterior choroidal artery. Further back, you'll find the pontine arteries, the basilar artery, and the vertebral arteries. Even lower down, you can trace the anterior spinal artery, the brachiocephalic trunk, the left subclavian artery, and the aortic arch feeding into this whole system. It's basically a traffic roundabout for blood flow at the base of the brain. Now let's switch gears to the dural venous sinuses. These are large venous channels that run between the periosteal and meningeal layers of the dura mater. They drain blood from the cerebral veins, and they also receive cerebrospinal fluid from the arachnoid granulations. All of that eventually empties into the internal jugular vein. Clinically, you can get venous sinus thrombosis that shows up with signs of increased intracranial pressure, like headache, seizures, papilledema, or focal neurologic deficits. Sometimes it can even lead to venous hemorrhage, and it's often associated with hypercoagulable states, things like pregnancy, oral contraceptive use, or factor V Leiden mutation. Now, let's walk through the main sinuses. The superior sagittal sinus. This is the main location where cerebrospinal fluid returns through the arachnoid granulations. The inferior sagittal sinus, which runs along the bottom edge of the falx cerebri. The great cerebral vein of Galen, which drains deep structures. The straight sinus, formed by the inferior sagittal sinus and the vein of Galen. The sphenoparietal sinus and the superior ophthalmic vein, which both drain toward the cavernous sinus. The cavernous sinus itself, sitting on either side of the pituitary. The confluence of the sinuses, where the straight sinus, superior sagittal sinus, and occipital sinus all meet. From there, blood flows into the transverse sinus, then down into the sigmoid sinus, and finally out through the jugular foramen into the internal jugular vein. There's also the occipital sinus, a smaller channel along the midline at the back. All right, let's explore the ventricular system of the brain. We start with the lateral ventricles. They have an anterior horn, a posterior horn, and an inferior horn. From there, cerebrospinal fluid, or CSF, flows through the interventricular foramina of Monro into the third ventricle. Next, CSF moves from the third ventricle into the fourth ventricle through the cerebral aqueduct of Sylvius. From the fourth ventricle, it can exit into the subarachnoid space by two routes, through the foramina of Luschka, which are the lateral apertures, and through the foramen of Magendie, which is the medial aperture. From there, CSF can also continue into the central canal of the spinal cord. So, to map it out step by step. 1. Lateral ventricles. 2. Interventricular foramina of Monro. 3. Third ventricle. 4. Cerebral aqueduct of Sylvius. 5. Fourth ventricle. 6. Foramina of Luschka and Magendie. 7. Central canal of the spinal cord. Now, how is CSF made? It's produced by the choroid plexuses located in the lateral, third, and fourth ventricles. Once made, it travels into the subarachnoid space through the foramina of Luschka and Magendie. From there, it's reabsorbed by the arachnoid granulations, which then drain the CSF into the dural venous sinuses. Now let's flip to the brainstem, ventral view. From the top down, we see the olfactory bulb, cranial nerve 1, with the olfactory tract running backward. Next is the optic chiasm and the optic tract, cranial nerve 2. Below that sits the infundibulum and the mammillary bodies. Then the oculomotor nerve, cranial nerve 3, exits. The trochlear nerve, cranial nerve 4, is unique. It arises dorsally and immediately decussates, crossing over. At the level of the pons, the trigeminal nerve, cranial nerve 5, the abducens nerve, cranial nerve 6, the facial nerve, cranial nerve 7, and the vestibulocochlear nerve, cranial nerve 8, all exit. In the medulla, you'll find the glossopharyngeal nerve, cranial nerve 9, the vagus nerve, cranial nerve 10, the spinal accessory nerve, cranial nerve 11, and the hypoglossal nerve, cranial nerve 12. There's a simple way to remember. For cranial nerves exit above the pons, that's 1 through 4. For cranial nerves exit at the pons, that's 5 through 8. And 4 cranial nerves exit in the medulla, that's 9 through 12. And here's another trick. For cranial nerve nuclei are medial, cranial nerves 3, 4, 6, and 12. Think factors of 12, except 1 and 2. Also on the ventral surface, you can see the pons, the middle cerebellar peduncle, the pyramids, and the pyramidal decussation, which is where the motor fibers cross. Now the brainstem, dorsal view, with the cerebellum removed. Here you'll find the pineal gland, which secretes melatonin and regulates circadian rhythm. The anterior wall of the fourth ventricle sits below the pineal gland. You can also see the third ventricle, the thalamus, and then 2 pairs of colliculi, the superior colliculi and the inferior colliculi. The superior colliculi process visual stimuli. They direct eye and head movements, especially in response to things you see. The inferior colliculi handle auditory processing, directing eye movements to sounds you hear. An easy memory trick. Eyes are above ears, so the superior colliculus is for vision, and the inferior colliculus is for hearing. Finally, at the base, you'll see the superior, middle, and inferior cerebellar peduncles and the medulla. Cranial nerve nuclei, the control centers for the cranial nerves. These nuclei are located in the tegmentum portion of the brainstem, which is the middle section between the dorsal and ventral portions. Here's the breakdown. In the midbrain, you'll find the nuclei for cranial nerves 3 and 4. That's the oculomotor and trochlear nerves. In the pons, you've got the nuclei for cranial nerves 5, 6, 7, and 8. That's trigeminal, abducens, facial, and vestibulocochlear. In the medulla, there are nuclei for cranial nerves 9, 10, and 12, glossopharyngeal, vagus, and hypoglossal. And finally, in the spinal cord, you'll find the nucleus for cranial nerve 11, the spinal accessory nerve. Now, there's a nice rule for orientation. Lateral nuclei are sensory, and they come from the alar plate. Medial nuclei are motor, and they come from the basal plate. Between the two, there's a dividing line called the sulcus limitans. Let's look at the vagal nuclei specifically. The nucleus tractus solitarius processes visceral sensory information, things like taste, baroreceptors that sense blood pressure, and gut distension. It may also play a role in vomiting. This nucleus is linked with cranial nerves 7, 9, and 10, facial, glossopharyngeal, and vagus. The nucleus ambiguus provides motor innervation to the pharynx, the larynx, and the upper esophagus. That means it controls swallowing and palate elevation. This nucleus is linked with cranial nerves 9 and 10, glossopharyngeal and vagus. The dorsal motor nucleus sends autonomic parasympathetic fibers to the heart, the lungs, and the upper gastrointestinal tract. This one is associated with cranial nerve 10, the vagus. Now, if we take a cross-section through the midbrain, here's what we'll see. The superior colliculus, which processes visual stimuli. The cerebral aqueduct, carrying cerebrospinal fluid between the third and fourth ventricles. The oculomotor nucleus, controlling eye movements with the oculomotor fibers running forward. The medial lemniscus, carrying sensory information up from the spinal cord. The red nucleus, important in motor coordination. The substantia nigra, which produces dopamine and is critical for movement. And finally, the cerebral peduncle, carrying descending motor fibers from the cortex. All right, now we'll move down to the pons. At this level, you'll see the fourth ventricle sitting dorsally, right behind the pons. Running through the brainstem is the medial longitudinal fasciculus, an important tract for coordinating eye movements and head position. On the sides, you've got the middle cerebellar peduncle, which connects the pons to the cerebellum, and above that, the superior cerebellar peduncle. Emerging here is cranial nerve 5, the trigeminal nerve. Also in the pons, you'll find the locus coeruleus, a cluster of norepinephrine-producing neurons that's key for arousal, stress response, and attention. Deeper in the section, you'll see the medial lemniscus, which carries fine touch, vibration, and proprioception signals from the spinal cord up to the thalamus. And ventrally, the corticospinal and corticobulbar tracts run down toward the spinal cord and cranial nerve nuclei. These are the main highways for voluntary motor control. Now let's move further down into the medulla. Here too, the fourth ventricle sits dorsally, tapering down toward the central canal. The nucleus of cranial nerve 12, the hypoglossal nucleus, sits medially. Just nearby is the dorsal motor nucleus, which provides parasympathetic fibers, mainly for cranial nerve 10, the vagus nerve. The nucleus tractus solitarius is also here, processing visceral sensory information like taste, blood pressure, and gut sensation. The inferior cerebellar peduncle connects the medulla to the cerebellum. Cranial nerve 10, the vagus nerve, exits from this level, and its motor fibers are controlled by the nucleus ambiguus, which handles muscles of the pharynx, larynx, and upper esophagus. Running through the midline is the medial longitudinal fasciculus, just as in the pons, continuing its role in eye and head coordination. Again, the medial lemniscus is visible, carrying ascending sensory information. On the ventral side, you'll see the inferior olivary nucleus, an important relay station involved in motor learning and coordination, sending signals into the cerebellum. And right at the base, there are the pyramids, which house the corticospinal tracts, the descending motor fibers that cross over at the pyramidal decussation to control voluntary movement on the opposite side of the body. Cranial nerves and vessel pathways. We'll start at the top in the anterior cranial fossa, which is part of the ethmoid bone. Here we find the cribriform plate. This is where cranial nerve I, the olfactory nerve, passes through, carrying the smell fibers right into the nasal cavity. Now we move into the middle cranial fossa, carved into the sphenoid bone. The first opening here is the optic canal. It carries cranial nerve 2, the optic nerve, along with the ophthalmic artery, both running straight to the eye. Next is the superior orbital fissure. This one is crowded. It transmits cranial nerve 3, the oculomotor, cranial nerve 4, the trochlear, cranial nerve 6, the abducens, and cranial nerve V1, the ophthalmic division of the trigeminal nerve. Together, these nerves handle most of the eye movements and sensation from the upper face. The foramen rotundum carries cranial nerve V2, the maxillary division of the trigeminal nerve, supplying sensation to the midface. The foramen ovale carries cranial nerve V3, the mandibular division, which provides sensation to the lower face and motor supply to the muscles of mastication. And the foramen spinosum is where the middle meningeal artery enters, a very important vessel, because rupture here causes the classic epidural hematoma. Now we're in the posterior cranial fossa, made from the temporal and occipital bones. The internal auditory meatus carries cranial nerve 7, the facial nerve, and cranial nerve 8, the vestibulocochlear nerve. That's your facial expression and your hearing balance system traveling side by side. The jugular foramen transmits cranial nerves 9, 10, and 11, glossopharyngeal, vagus, and accessory, as well as the jugular vein. These are key for swallowing, parasympathetic control, voice, and head and shoulder movement. The hypoglossal canal carries cranial nerve 12, the hypoglossal nerve, which controls tongue movement. And finally, the foramen magnum, the great highway at the base of the skull. Through here, past the brainstem and spinal cord, the spinal root of cranial nerve 11, and the vertebral arteries. Cranial nerves and arteries. Now let's shift to how the cranial nerves are arranged alongside arteries in the brainstem. At the very top, cranial nerve 1, olfactory. Cranial nerve 2, optic. In the midbrain, medial, cranial nerve 3, the oculomotor nerve, and cranial nerve 4, the trochlear nerve. Both are involved in eye movement. The trochlear is special because it exits dorsally, but its nucleus is still medial in the midbrain. In the pons, medial, cranial nerve 6, the abducens nerve, also for eye movement. Lateral, cranial nerve 5, the trigeminal nerve, and cranial nerves 7 and 8, the facial and vestibulocochlear nerves. These take care of face sensation, facial expression, and hearing balance. In the medulla, medial, cranial nerve 12, the hypoglossal nerve, which moves the tongue. Lateral, cranial nerves 9, 10, and 11, glossopharyngeal, vagus, and accessory. These handle swallowing, speech, parasympathetics, and shoulder movement. Now let's layer in the arteries that supply these areas. At the front of the brain, anterior cerebral artery and anterior communicating artery. Nearby is the ophthalmic artery, branching off the internal carotid artery. The middle cerebral artery also comes from the internal carotid, supplying most of the lateral cerebral hemisphere. From the internal carotid, you also get the anterior choroidal artery. Behind that lies the posterior communicating artery, which connects forward circulation to the back. Then the posterior cerebral artery, supplying the occipital lobes and visual cortex. Dropping lower, there's the superior cerebellar artery, then the large basilar artery running up the midline of the pons. Off the basilar, you also get the anterior inferior cerebellar artery and the labyrinthine artery, which supplies the inner ear. Finally, from the vertebral arteries come the posterior inferior cerebellar artery and the anterior spinal artery. All right, let's take a ride through the 12 cranial nerves, the special wires that connect the brain to the body. Each one's got its own personality, its own job, and even its own little mnemonic word to help us remember. We kick off with cranial nerve number 1, the olfactory nerve. This one's all about smell, and here's the cool part. It's the only cranial nerve that skips the thalamus when sending signals to the cortex. Straight from the nose to the brain. Pure sensory. The mnemonic word for it is some. Next up, cranial nerve 2, the optic nerve. That's your vision highway. No optic nerve, no sight. Also pure sensory. Its word is say. Cranial nerve 3, oculomotor. Now this guy is busy. It moves most of the eye muscles, superior rectus, inferior rectus, medial rectus, and the inferior oblique. It also shrinks your pupils with the sphincter pupillae, focuses your lens with the ciliary muscle, and even opens your eyelid using levator palpebrae. Pure motor, and its mnemonic word is merry. Cranial nerve 4, trochlear. Small but mighty. It controls the superior oblique muscle, the one that lets you look down and in. Fun fact, it's the only cranial nerve that crosses over, so it controls the opposite side. Also pure motor. The word is money. Now comes cranial nerve 5, the trigeminal nerve. This one's a mix, sensory and motor. It lets you chew, feel your face through 3 branches, ophthalmic, maxillary, and mandibular, and even feel the front 2/3 of your tongue. Oh, and it helps dampen loud noises using the tensor tympani. both sensory and motor. Word, but cranial nerve 6, abducens. Simple. It moves the lateral rectus muscle, pulling your eye outward. Pure motor. Where am I? Cranial nerve 7, facial nerve. This one's full of personality. It makes your facial expressions, closes your eyes with the orbicularis oculi, and even adjusts sound volume with the stapedius muscle. It carries taste from the front 2/3 of your tongue via the chorda tympani and controls tears and saliva from the submandibular and sublingual glands. Both sensory and motor. Word, brother. Cranial nerve 8, vestibulocochlear. Think balance and hearing, your inner ear's best friend. Pure sensory. Word says cranial nerve 9, glossopharyngeal. A real multitasker. Taste and sensation from the back third of your tongue. Swallowing, salivation from the parotid gland, and monitoring blood chemistry and pressure from the carotid body and sinus. It even lifts your pharynx and larynx using the stylopharyngeus muscle. Both sensory and motor. Word big. Cranial nerve 10, vagus. The wanderer. It carries taste from the supraglottic region, helps you swallow, lifts your soft palate, moves your uvula, powers your voice, and controls the cough reflex. Plus, it sends parasympathetic signals to your thoracic and abdominal organs, and keeps an eye on blood pressure through the aortic arch receptors. Both sensory and motor. Word, brains. Cranial nerve 11, accessory. This one's motor only. It lets you shrug your shoulders with trapezius and turn your head with sternocleidomastoid. Word, matter. Finally, cranial nerve 12, hypoglossal. All about tongue movement. Motor only. Word, most. So stringing the mnemonic together. Some say merry money, but my brother says big brains matter most. Cranial nerve reflexes. Now let's flip it and look at how these nerves work together in reflexes. For the accommodation reflex, when your eyes adjust to focus on something near, cranial nerve 2, optic, is the afferent limb, and cranial nerve 3, oculomotor, is the efferent limb. The corneal reflex, touch the cornea, you blink. Sensation comes in through cranial nerve 5-1, the ophthalmic division of trigeminal, specifically the nasociliary branch. The blink goes out through cranial nerve 7, facial, using the temporal and zygomatic branches that close orbicularis oculi. The cough reflex, both afferent and efferent, are cranial nerve 10, vagus, though the motor response also involves the phrenic nerve and spinal nerves. The gag reflex, sensation comes in through cranial nerve 9, glossopharyngeal. The motor response goes out through cranial nerve 10, vagus. The jaw jerk reflex, tap the jaw, it kicks. Both afferent and efferent travel through cranial nerve 5-3, the mandibular division. Sensory comes from muscle spindles in the masseter, motor goes back to the masseter. The lacrimation reflex, touch near the eye, you tear. Afferent is cranial nerve 5-1. Efferent is cranial nerve 7, facial. And remember, losing this reflex doesn't stop emotional crying. Those tears still come. And the pupillary light reflex, shine light in the eye, the pupil constricts. Afferent is cranial nerve 2, optic. Efferent is cranial nerve 3, oculomotor. Muscles of mastication. Let's start with chewing. You've got 4 main muscles of mastication. 3 of them close the jaw, the masseter, temporalis, and medial pterygoid. Easy way to remember that. My teeth munch. Then there's the odd one out, the lateral pterygoid. Instead of closing, it opens the jaw and also helps protrude it forward. All 4 of these muscles are controlled by the mandibular branch of the trigeminal nerve, cranial nerve E3. So, chew, bite, and open wide, all powered by trigeminal V3. Spinal nerves. Now, let's move down to the spinal cord. There are 31 pairs of spinal nerves in total. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Here's how they exit. The cervical nerves C1 through C7 come out above their corresponding vertebrae. For example, C3 exits above the third cervical vertebra. But then comes a twist, the C8 spinal nerve. It sneaks out below C7 and above T1. After that, all spinal nerves exit below their corresponding vertebrae. For instance, L2 exits below the second lumbar vertebra. Lower extent of the spinal cord. In adults, the spinal cord itself ends at about the lower border of L1 to L2. But the subarachnoid space, the fluid-filled area containing cerebrospinal fluid, or CSF, stretches further down to the lower border of S2. That's why when doctors do a lumbar puncture, they usually go between L3 and L4 or L4 and L5. This area is called the cauda equina region, a bundle of spinal nerves floating in CSF, so you can safely collect fluid without hitting the actual spinal cord. A classic reminder, to keep the cord alive, keep the needle between L3 and L5. The lumbar puncture needle passes through these layers in order. Skin, fascia and fat, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space. This is where an epidural anesthesia needle would stop. Dura mater, arachnoid mater, and finally, into the subarachnoid space, where CSF is collected. Conus medullaris and cauda equina syndrome. Now, for a serious note. At the very end of the spinal cord is the conus medullaris, and trailing nerves called the cauda equina. Compression of this area, whether from a slipped disc, a tumor, or trauma, can cause conus medullaris syndrome or cauda equina syndrome, both rare but urgent neurosurgical emergencies. Here's how they show up. Conus medullaris syndrome gives symmetric symptoms, like lower limb weakness with upper motor neuron signs, think stiffness and spasticity. Cauda equina syndrome gives asymmetric symptoms, like weakness in the legs with lower motor neuron signs, floppiness, and loss of reflexes. Both can cause radicular low back pain, saddle or perianal numbness, and bladder or bowel dysfunction. If you see these signs, it's a red flag for immediate treatment. Spinal cord levels and associated tracts. Now let's picture the spinal cord and how its tracts are arranged. There's a neat rule to remember. Legs are lateral. In a lateral corticospinal tract and in the spinothalamic tract, the fibers from the legs sit on the outside, while the fibers from the arms sit more toward the middle. But in the dorsal columns, it flips a little. Think of your body standing in anatomical position, with your arms outside and legs inside. That's how the dorsal columns are organized. Arms are represented laterally. Legs are represented medially. Spinal tract anatomy and functions. All right, let's dive into the spinal tracts, the highways carrying messages up and down the spinal cord. Quick rule to keep in mind. The spinothalamic tract and the dorsal column are ascending tracts. That means they're carrying information up to the brain. They synapse first, then cross over. The corticospinal tract is a descending tract, carrying commands down from the brain to the body. This one crosses first, then synapses. Now, let's break them down one by one. Spinothalamic tract. This carries pain and temperature. The first-order neuron starts at a sensory nerve ending, like A delta fibers and C fibers, in a pseudounipolar neuron sitting in the dorsal root ganglion. It enters the spinal cord. The first synapse happens right in the posterior horn of the spinal cord. Then the second-order neuron decussates, meaning it crosses over in the spinal cord itself through the anterior white commissure and then ascends contralaterally, heading upward. It makes its second synapse in the ventral posterolateral nucleus of the thalamus. From there, the third-order neuron projects straight to the primary somatosensory cortex. Dorsal column. This one carries pressure, vibration, fine touch, and conscious proprioception. Here, the first-order neuron begins at the sensory nerve ending, again from a pseudounipolar neuron in the dorsal root ganglion. It enters the spinal cord and ascends ipsilaterally, staying on the same side within the dorsal columns. If it's lower limb information, it goes to the nucleus gracilis, think grass on the ground. If it's upper limb information, it goes to the nucleus cuneatus, think clouds in the sky. These are in the ipsilateral medulla. That's the first synapse. Then the second-order neuron decussates in the medulla and ascends contralaterally as the medial lemniscus. It makes the second synapse in the ventral posterolateral nucleus of the thalamus. And finally, the third-order neuron projects to the primary somatosensory cortex. Corticospinal tract. This is the descending tract for voluntary movement. The upper motor neuron starts in the primary motor cortex. It descends ipsilaterally through the posterior limb of the internal capsule and into the cerebral peduncle. When it hits the caudal medulla, it decussates at the pyramidal decussation and then continues descending contralaterally. It makes its first synapse in the anterior horn of the spinal cord. From there, the lower motor neuron leaves the spinal cord and its axon travels out to meet the skeletal muscle at the neuromuscular junction. That's where the signal is delivered. Clinical reflexes. Here's an easy trick. Reflexes count up in order, and the main nerve root is in bold. The Achilles reflex is S1 and S2, rhyme it as buckle my shoe. The patellar reflex is L2 to L4, kick the door. The biceps and brachioradialis reflexes are C5 and C6, pick up sticks. The triceps reflex is C6, C7, and C8, lay them straight. There are also two extra ones to know. The cremasteric reflex, L1 and L2. Stroke the inner thigh, and the testicle moves. Easy memory, testicles move. And the anal wink reflex, S3 and S4. Stroke the perianal region, and you'll see contraction. The phrase? Winks galore. Reflexes are graded from 0 to 4. 0 means absent. 1+ means hypoactive. 2+ is normal. 3+ is hyperactive. And 4+ is clonus. Now let's move into the primitive reflexes, the ones that belong in babies, not adults. These are central nervous system reflexes present in healthy infants, disappearing within the first year as the frontal lobe takes over. If they reappear in adults, it's usually a sign of frontal lobe lesions because of the loss of inhibition. Here's the list. The Moro reflex, the classic hang on for life reflex. When startled, the baby abducts and extends the arms, then quickly brings them back in. The rooting reflex, stroke the cheek or mouth, and the baby turns toward it, looking for a nipple. The sucking reflex, touch the roof of the mouth, and the baby starts sucking. The palmar reflex, stroke the palm, and the fingers curl tightly. The plantar reflex, here's where the Babinski sign comes in. Stroke the sole, and instead of curling, the big toe dorsiflexes and the other toes fan out. Normal for infants, but in adults it points to an upper motor neuron lesion. And finally, the Gallant reflex, stroke one side of the spine while the baby is face down and the lower body flexes toward that side. Now let's tie it together with the landmark dermatomes, the sensory map of the body. C2 covers the posterior half of the skull. C3 is the high turtleneck shirt area. Remember, C3, 4, and 5 keep the diaphragm alive. That's why diaphragm and gallbladder pain can be referred to the right shoulder through the phrenic nerve. C4 is the low collar shirt region. C6 includes the thumbs. Think of a thumbs up sign, it looks like a 6. T4 lines up with the nipples. Easy. T4 at the teat pore. T7 is at the xiphoid process. Memory tip, xiphoid has 7 letters. T10 is at the umbilicus, the belly button, and that's also the referred pain point in early appendicitis. L1 lines up with the inguinal ligament. L4 is the kneecaps. Think down on all fours. And S2, S3, and S4 supply sensation to the penile and anal zones. Classic memory. S2, 3, for keep the penis off the floor. So when you put it all together, reflexes, primitive reflexes, and dermatomes, you've got a clear map of how the nervous system is wired for both motor and sensory responses. Now let's move to pathology of neurology. First up, common brain lesions. If the lesion is in the prefrontal cortex, we get what's called frontal lobe syndrome. This means disinhibition, hyperphagia, impulsivity, loss of empathy, impaired executive function, and even akinetic mutism. A classic cause is frontotemporal dementia. Lesions in the frontal eye fields make the eyes look toward the lesion, meaning they look away from the side of the hemiplegia. This is often seen in middle cerebral artery strokes. On the flip side, lesions in the paramedian pontine reticular formation make the eyes look away from the lesion, in other words, toward the side of the hemiplegia. Damage to the dominant parietal cortex produces Gerstmann syndrome. That's the tetrad, agraphia, acalculia, finger agnosia, and left-right disorientation. Damage to the non-dominant parietal cortex produces hemispecial neglect syndrome. The patient ignores the opposite side of the world. In the basal ganglia, lesions cause tremor at rest, chorea, and athetosis. Think Parkinson's disease and Huntington's disease. Lesions in the subthalamic nucleus cause contralateral hemibolismus, those wild, flinging movements of one side. The mammillary bodies, when bilaterally injured, produce Wernicke-Korsakoff syndrome, usually due to thiamine deficiency. Bilateral lesions of the amygdala cause Kluver-Bucy syndrome, disinhibition with hyperphagia, hypersexuality, and hyperorality. Classic cause? Herpes simplex virus type 1 encephalitis. Lesions of the hippocampus, especially bilateral, cause profound anterograde amnesia, meaning the patient can't form new memories. Seen in Alzheimer's disease. Lesions in the dorsal midbrain produce Parano syndrome, often due to pineal gland tumors. Lesions in the reticular activating system reduce arousal and wakefulness, even leading to coma. Damage to the medial longitudinal fasciculus causes internuclear ophthalmoplegia, impaired adduction of the eye on the side of the lesion, and nystagmus of the opposite eye when it abducts. A classic finding in multiple sclerosis. Lesions in the cerebellar hemispheres cause intention tremor, limb ataxia, and loss of balance. Because the cerebellum's output is double-crossed, the deficits are ipsilateral, patients fall toward the side of the lesion. Remember, cerebellar hemispheres are lateral, so they affect lateral limbs. Lesions in the cerebellar vermis, which is central, cause truncal ataxia, that wide-based, drunken sailor gait, along with nystagmus and dysarthria. Chronic alcohol overuse often leads to vermis degeneration. Let's start with abnormal motor posturing. When a lesion occurs above the red nucleus, usually in the cerebral cortex, the rubrospinal and vestibulospinal tracts become overactive. This produces decorticate posturing, also called flexor posturing. You'll see the upper limbs flex and the lower limbs extend. A quick way to remember: your hands are near the COR, the heart, and decorticate. Now, if the lesion is between the red nucleus and the vestibular nuclei, which means in the brainstem, then the vestibulospinal tract dominates. That gives you decerebrate posturing or extensor posturing. Here, both the upper and lower limbs extend. And the key clinical pearl: decerebrate posturing carries a worse prognosis compared to decorticate. Ischemic brain disease and stroke. All right, let's dive into strokes and brain ischemia. First thing to know, neurons don't like being starved of oxygen. In fact, irreversible neuronal injury starts after just 5 minutes of hypoxia. And the most vulnerable regions? Think of the memory phrase, vulnerable hippos need pure water. That's hippocampus, especially the CA1 region, the neocortex, Purkinje cells of the cerebellum, and the watershed areas. Now, what happens in the brain over time after an ischemic event? At 12 to 24 hours, you'll see red neurons, eosinophilic cytoplasm with shrunken pycnotic nuclei. By 24 to 72 hours, necrosis sets in and neutrophils flood the area. At 3 to 5 days, macrophages, specifically microglia, take over and start clearing debris. By 1 to 2 weeks, astrocytes kick in with reactive gliosis, and you'll also see vascular proliferation. And after more than 2 weeks, a firm glial scar remains. So in sequence, it goes red neurons, neutrophils, microglia, astrocytes, and blood vessel scar. Now let's talk stroke imaging. The first step is always a non-contrast CT scan to rule out hemorrhage before giving tissue plasminogen activator, or TPA. CT scans pick up ischemic changes around 6 to 24 hours later. But if you really want to catch things early, a diffusion-weighted MRI can show ischemia in as little as 3 to 30 minutes. Ischemic stroke. Remember, ischemia progresses to infarction, which then ends in liquefactive necrosis. There are 3 types of ischemic strokes. 1. Thrombotic stroke, caused by a clot forming directly at the site of infarction, usually in the middle cerebral artery, and often on top of a ruptured atherosclerotic plaque. 2. Embolic stroke. Here, the clot travels from somewhere else. It often hits multiple vascular territories. Classic sources are atrial fibrillation, carotid artery stenosis, deep vein thrombosis with a patent foramen ovale, that's a paradoxical embolism, and infective endocarditis. 3. Hypoxic stroke. This is due to global hypoperfusion or hypoxemia, like during cardiac arrest or cardiovascular surgery. It tends to hit those watershed areas. So, how do we treat ischemic stroke? TPA if the patient comes in within 3 to 4.5 hours of symptom onset, and only if there's no hemorrhage or bleeding risk. Thrombectomy if there's a large artery occlusion. Long-term, reduce risk with medical therapy, aspirin, clopidogrel, control of blood pressure, blood sugar, and lipids. Smoking cessation is huge. And of course, treat conditions that raise risk, like atrial fibrillation or carotid stenosis. Now, let's touch on a related concept, the transient ischemic attack, or TIA. This is a brief, reversible episode of focal neurologic dysfunction, without acute infarction, meaning the MRI is negative. Most resolve in under 15 minutes. The cause is still ischemia, often from an embolus or small vessel stenosis. Sometimes it shows up as amaurosis fugax, a sudden, temporary loss of vision from retinal artery emboli, often from carotid disease. Finally, let's talk cerebral edema, swelling of the brain. This raises intracranial pressure and comes in 2 major flavors. Cytotoxic edema, intracellular fluid buildup. This happens because of osmotic shifts like sodium-potassium ADPase pump failure. Causes include early ischemia, hyperammonemia, or syndrome of inappropriate antidiuretic hormone secretion. Vasogenic edema, extracellular fluid buildup, caused by breakdown of the blood-brain barrier and increased permeability. Causes include late ischemia, trauma, hemorrhage, inflammation, and tumors. On imaging, you'll see that hazy swelling around the lesion. Effects of strokes by artery. Okay, strokes hit different arteries, and depending on the artery, you get very specific symptoms. Let's break it down by circulation. Anterior circulation. First up, the anterior cerebral artery, or ACA. This artery supplies the motor and sensory cortices for the lower limb. So when it's blocked, you see contralateral paralysis and sensory loss in the lower limb, plus sometimes urinary incontinence. Think ACA for legs and pee. Now, the middle cerebral artery, the big one. It supplies the motor and sensory cortices for the upper limb and face. So the stroke gives you contralateral paralysis and sensory loss in the lower face and upper limb. But MCA strokes can also hit the temporal lobe, which houses Wernicke's area, and the frontal lobe, where Broca's area lives. If the stroke hits the dominant hemisphere, usually the left, you'll get aphasia. Broca if it's anterior, Wernicke if it's posterior. If it hits the non-dominant hemisphere, usually the right, you'll get hemi-neglect, ignoring the opposite side of the world. And here's a detail. Wernicke's aphasia is often paired with a right superior quadrant visual field defect, thanks to temporal lobe involvement. So remember, Wernicke equals word salad plus what's missing in the visual field. Next, the lenticulostriate arteries. These are small vessels branching off the MCA, supplying the striatum and internal capsule. When these get blocked, you get contralateral paralysis, but here's the catch. There are no cortical signs like aphasia, neglect, or visual field loss. It's a pure motor stroke, and it's the most common type of lacunar infarct. These happen from microatheroma or lipohyalinosis, small vessel disease, usually from unmanaged hypertension. Posterior circulation. Now let's flip to the back. The posterior cerebral artery, or PCA, supplies the occipital lobe. A PCA stroke gives you contralateral hemianopia with macular sparing. That means vision is gone on one side, but the macula is preserved. It can also cause alexia without agraphia. The person can write, but can't read if the dominant hemisphere and splenium of the corpus callosum are involved. In the non-dominant hemisphere, a PCA stroke can cause prosopagnosia, inability to recognize familiar faces. One special PCA syndrome is Weber syndrome, a midbrain stroke from occlusion of paramedian branches of the PCA. Symptoms are ipsilateral cranial nerve 3 palsy and contralateral hemiplegia because the cerebral peduncle is damaged. Next up, the basilar artery. This one's classic for locked-in syndrome. The stroke hits the pons, medulla, and lower midbrain, including corticospinal and corticobulbar tracts, ocular cranial nerve nuclei, and the paramedian pontine reticular formation. If the reticular activating system is spared, consciousness is preserved. The person is awake but quadriplegic, unable to move arms, legs, face, mouth, or tongue voluntarily. They can usually only blink and move eyes vertically. That's why it's called locked in the basement. Now the anterior inferior cerebellar artery, or AICA. An AICA stroke hits a lot of structures. The facial nerve nuclei, vestibular nuclei, trigeminal nucleus, spinothalamic tract, sympathetic fibers, cerebellar peduncles, and the inner ear. The symptoms? Quite a list. Facial paralysis, but this time it's an actual lower motor neuron lesion, unlike cortical strokes. Decreased lacrimation, salivation, and taste from the anterior 2/3 of the tongue. Vomiting, vertigo, and nystagmus for vestibular involvement. Loss of pain and temperature sensation from the contralateral body and from the ipsilateral face. Ipsilateral Horner syndrome. Ipsilateral ataxia and dysmetria from cerebellar involvement. Plus ipsilateral sensorineural deafness and vertigo because the labyrinthine artery, a branch of AICA, supplies the inner ear. One quick tip. Facial nerve involvement is specific for AICA strokes. That's how you tell it apart from pica strokes. Posterior inferior cerebellar artery. The area of lesion includes nucleus ambiguus, cranial nerves 9 and 10, vestibular nuclei, lateral spinothalamic tract, spinal trigeminal nucleus, sympathetic fibers, and inferior cerebellar peduncle. The symptoms are dysphagia, hoarseness, gag reflex, hiccups, vomiting, vertigo, nystagmus, loss of pain and temperature sensation from contralateral body and ipsilateral face, ipsilateral Horner syndrome, ipsilateral ataxia, dysmetria. This is called lateral medullary syndrome, also known as Wallenberg syndrome. Nucleus ambiguous effects are specific to posterior inferior cerebellar artery lesions. Don't pick a pica lame horse that can't eat, hoarseness, and dysphagia. Anterior spinal artery. The area of lesion includes corticospinal tract, medial lemniscus, and caudal medulla involving the hypoglossal nerve. The symptoms are contralateral paralysis of upper and lower limbs, contralateral loss of proprioception, and ipsilateral hypoglossal dysfunction with the tongue deviating ipsilaterally. This is medial medullary syndrome, caused by infarct of paramedian branches of anterior spinal artery and or vertebral arteries. Ants love M&Ms. Neonatal intraventricular hemorrhage. This is bleeding into ventricles, shown by the arrow in the illustration as blood in the intraventricular space. It is at risk in premature and low birth weight infants. It originates in the germinal matrix, a highly vascularized layer within the subventricular zone. It is due to reduced glial fiber support and impaired autoregulation of blood pressure in premature infants. It can present with altered level of consciousness, bulging fontanelle, hypotension, seizures, and coma. Extracranial injuries. These occur during birth, leading to blood accumulation within the scalp and skull. Commonly seen in vacuum-assisted delivery. Disorders. Caput succedaneum. Presentation: self-limited, benign, edematous swelling above periosteum, crosses suture lines. May be caused by prolonged fetal birth canal engagement. Resolve spontaneously. Subgaleal hemorrhage. Presentation: serious, life-threatening damage of fetal emissary veins, blood accumulation between periosteum and ganglia aponeurosis. Presence as diffuse, fluctuant scalp swelling extending posteriorly and laterally. May lead to anemia and hypovolemic shock. Cephalohematoma. Presentation: blood accumulation between skull and periosteum, does not cross suture lines. May be caused by forceps delivery. Presence with firm, localized swelling over parietal or occipital lobe. May lead to indirect hyperbilirubinemia. Intracranial hemorrhage. Epidural hematoma. This is rupture of the middle meningeal artery, which is a branch of the maxillary artery, often secondary to skull fracture involving the pterion, the thinnest area of the lateral skull. It might present with a transient loss of consciousness, then recovery, called a lucid interval, followed by rapid deterioration due to hematoma expansion. You can see a scalp hematoma and rapid intracranial expansion under systemic arterial pressure can lead to transtentorial herniation and cranial nerve 3 palsy. On CT scan, it shows as a biconvex, liniform, hyperdense blood collection that does not cross suture lines. Subdural hematoma. This is rupture of bridging veins. It can be acute, caused by traumatic high-energy impact, appearing brighter or hyperdense on CT. Or it can be chronic, associated with mild trauma, cerebral atrophy, increased age, or chronic alcohol overuse, appearing darker or hypodense on CT. It is also seen in shaken babies. On imaging, it shows as a crescent-shaped hemorrhage that crosses suture lines. It can cause midline shift, and you may see findings of acute hyperdense borders on top of a chronic hypodense crescent hemorrhage. Subarachnoid hemorrhage. This is bleeding due to trauma or rupture of an aneurysm, such as a saccular aneurysm or an arteriovenous malformation. The time course is rapid. Patients typically complain of the worst headache of my life. Lumbar puncture shows bloody or yellow xanthochromic fluid. Complications include vasospasm, which can occur due to blood breakdown or a rebleed 3 to 10 days after the hemorrhage, leading to ischemic infarct. Nimodipine is used to prevent or reduce vasospasm. There is also an increased risk of developing communicating and non-communicating hydrocephalus. Intraparenchymal hemorrhage. This is most commonly caused by systemic hypertension. It is also seen with amyloid angiopathy, which lead to recurrent lobar hemorrhagic strokes in older adults, as well as arteriovenous malformations, vasculitis, and neoplasms. It may also be secondary to reperfusion injury in ischemic stroke. Hypertensive hemorrhages, also called Charcot-Bouchard microaneurysms, most often occur in the putamen or globus pallidus of the basal ganglia, supplied by the lenticulostriate vessels. Other common sites include the internal capsule, thalamus, pons, and cerebellum. Thalamic pain syndrome and related disorders. Thalamic pain syndrome. This is severe, treatment-resistant neuropathic pain following thalamic lesions. It may be due to occlusion of a lenticulostriate artery. It begins with initial paresthesias, followed weeks to months later by allodynia, where ordinarily painless stimuli cause pain, hyperalgesia, which is hypersensitivity to pain, and dysesthesia, an altered sensation, all occurring on the contralateral side of the body. Phantom limb pain. This is the sensation of burning, aching, or electric shock, like pain in a limb that is no longer present. It is common after amputation and is associated with reorganization of the primary somatosensory cortex. Diffuse axonal injury. This is traumatic shearing of white matter tracts during rapid acceleration and/or deceleration of the brain, such as in a motor vehicle accident. It usually results in devastating neurologic injury, often causing coma or a persistent vegetative state. On MRI, it shows multiple lesions, punctate hemorrhages involving the white matter tracts. Aphasia. This is a higher-order language deficit, an inability to understand, produce, or use language appropriately. It is caused by pathology in the dominant cerebral hemisphere, which is usually the left. It must be distinguished from dysarthria, which is simply the motor inability to produce speech, a movement deficit. Types of aphasia. Broca aphasia, also called expressive aphasia. This involves Broca's area in the inferior frontal gyrus of the frontal lobe. The speech is non-fluent, but language comprehension is intact. Patients appear frustrated, and insight is intact. Remember, Broca equals broken boca, boca meaning mouth in Spanish. Wernicke aphasia, also called receptive aphasia. This involves Wernicke's area in the superior temporal gyrus of the temporal lobe. The speech is fluent, but language comprehension is impaired. Patients do not have insight. Wernicke is a word salad and makes no sense. Conduction aphasia. This can be caused by damage to the arcuate fasciculus. The hallmark is impaired speech repetition. Global aphasia. This occurs when both Broca and Wernicke areas are affected. It presents with non-fluent speech combined with impaired language comprehension. Aneurysm. An aneurysm is an abnormal dilation of an artery due to weakening of the vessel wall. First, saccular aneurysm. This is also called a Berry aneurysm. It occurs at bifurcations in the circle of Willis. The most common site is the junction of the anterior communicating artery and the anterior cerebral artery. It is associated with autosomal dominant polycystic kidney disease and Ehlers-Danlos syndrome. Other risk factors include advanced age, hypertension, and tobacco smoking. These aneurysms are usually clinically silent until rupture, and rupture is the most common complication. When they rupture, they cause a subarachnoid hemorrhage. That's the classic worst headache of my life, or thunderclap headache, and they may also produce focal neurologic deficits. Sometimes, even before rupture, they can cause symptoms by direct compression of surrounding structures as they grow. Let's go through site-specific effects. Anterior communicating artery aneurysm. Compression here can cause bitemporal hemianopia due to compression of the optic chiasm, as well as visual acuity deficits. If it ruptures, it can cause ischemia in the anterior cerebral artery distribution, leading to contralateral lower extremity hemiparesis and sensory deficits. Middle cerebral artery aneurysm. Rupture here causes ischemia in the middle cerebral artery distribution, which leads to contralateral upper extremity and lower facial hemiparesis and sensory deficits. Posterior communicating artery aneurysm. Compression here produces ipsilateral cranial nerve 3 palsy, which shows up as a dilated pupil, called mydriasis or a blown pupil, along with ptosis and a down and out eye. Basilar tip aneurysm is also possible, but less commonly discussed in terms of compression syndromes. Now, Charcot-Bouchard microaneurysm. These are common, and they are associated with chronic hypertension. They affect small vessels, such as the lenticulostriate arteries in the basal ganglia and the thalamus, and they can cause hemorrhagic intraparenchymal strokes. Importantly, they're not visible on angiography. Now, let's switch gears. Fever versus heat stroke. Fever. The pathophysiology is cytokine activation during inflammation, such as an infection. The temperature is usually less than 40 degrees Celsius, which is 104 degrees Fahrenheit. A complication can be febrile seizure, which is benign and usually self-limiting. Management includes acetaminophen or ibuprofen for comfort, though these do not prevent future febrile seizures, and antibiotic therapy if indicated. Heat stroke. Here, the pathophysiology is an inability of the body to dissipate heat, such as during exertion. The temperature is usually greater than 40 degrees Celsius or 104 degrees Fahrenheit. Complications are much more severe and include central nervous system dysfunction, such as confusion, rhabdomyolysis, acute kidney injury, acute respiratory distress syndrome, and disseminated intravascular coagulation. Management is rapid external cooling, along with rehydration and electrolyte correction. Seizures. Seizures are characterized by synchronized, high-frequency firing of neurons. They usually have 3 phases. First is the aura. This is the early part of a seizure, and it might include odd smells or strange tastes. Next is the ictal phase, which is the period from the very first symptom all the way to the end of seizure activity. And finally comes the postictal phase. That's the recovery period, when the brain gradually returns back to its pre-seizure baseline level of function and awareness. Now, seizures can be divided into focal or generalized. Focal seizures start in a single area of the brain, most commonly in the medial temporal lobe. There are 2 types: focal aware seizures, which used to be called simple partial seizures. In these, consciousness stays intact. Symptoms can be motor, sensory, autonomic, or even psychic in nature. Focal impaired awareness seizures, which used to be called complex partial seizures. In these, consciousness is impaired, and there are often automatisms, little repetitive behaviors like lips smacking or hand wringing. Generalized seizures are diffuse, meaning they involve both hemispheres. The main types include absence seizures, also known as petit mal seizures. On EEG, they show classic 3 Hz spike and wave discharges. These episodes are short, usually about 10 seconds, but can happen very frequently. They often present as a blank stare, sometimes with automatisms, but importantly, there is no postictal confusion. They can be triggered by hyperventilation. Myoclonic seizures, which are quick, repetitive jerks. There's no loss of consciousness and no postictal confusion. These alternate between stiffening and rhythmic movements and are followed by postictal confusion. They often involve urinary incontinence or tongue biting. Tonic seizures, which are just sustained stiffening. Atonic seizures, also called drop seizures, where the person suddenly falls to the floor. These are commonly mistaken for fainting. Now, epilepsy is defined as a disorder of recurrent, unprovoked seizures. That's important. Febrile seizures do not count as epilepsy. There's also convulsive status epilepticus, which is either a seizure lasting 5 minutes or more, or repeated seizures without any return to baseline consciousness in between. This is dangerous and may result in brain injury. The causes of seizures vary by age. In children under 18, common causes include genetic conditions, infection like febrile seizures, trauma, congenital malformations, and metabolic issues. In adults aged 18 to 65, causes often include tumors, trauma, stroke, and infection. In adults over 65, stroke becomes the most common cause, followed by tumor, trauma, metabolic problems, and infection. Finally, there are psychogenic non-epileptic events, which look like seizures but are not true epileptic activity. They resemble prolonged episodes, often more than 1 minute, and can look like syncopal events or tonic-clonic seizures. Unlike real seizures, they do not have a postictal phase. They often come with autonomic disturbances or dramatic vocalizations, and they can even have a preceding aura. They are more common in females and are strongly associated with psychiatric disorders or substance use. Video EEG during an event will be normal. And that's the overview. Seizures can be focal, generalized, or psychogenic, each with their own features, phases, and causes. Headaches. Headaches happen when there's pain due to irritation of structures inside or outside the skull, things like the meninges or blood vessels. We divide them into primary headaches and secondary headaches. Primary headaches include tension type, migraine, and cluster headaches. Secondary headaches include causes like medication overuse, meningitis, subarachnoid hemorrhage, hydrocephalus, neoplasia, and giant cell arteritis. Tension type headache. This one is bilateral. It lasts more than 30 minutes, typically 4 to 6 hours, and the pain is steady, kind of like a tight band around the head. There's no nausea or vomiting. At most, you get just one of either photophobia or phonophobia. Importantly, there is no aura. This is the most common type of primary headache, and it's more common in females. For treatment of acute episodes, we use analgesics, nonsteroidal anti-inflammatory drugs, or acetaminophen. For prevention, tricyclic antidepressants such as amitriptyline and behavioral therapy are helpful. Migraine. These headaches are unilateral. They last anywhere from 4 to 72 hours. The pain is pulsating and usually comes with nausea, photophobia, and phonophobia. There may also be an aura. The mechanism involves irritation of the trigeminal nerve, the meninges, or blood vessels, with the release of vasoactive neuropeptides like substance P and calcitonin gene-related peptide. Migraines are more common in females. A good way to remember migraines is POUND. Pulsatile, 1-day duration, unilateral, nausea, and disabling. Treatment for acute attacks includes NSAIDs, triptans, dihydroergotamine, and antiemetics like prochlorperazine or metoclopramide. For prevention, we use lifestyle changes such as improving sleep, exercise, and diet, as well as medications including beta blockers, amitriptyline, topiramate, valproate, botulinum toxin, and the newer anti-CGRP monoclonal antibodies. Cluster headache. This one is also unilateral, but instead of steady or pulsating pain, it's excruciating periorbital pain. Attacks last 15 minutes to 3 hours, and they are repetitive. They come with autonomic symptoms like lacrimation, rhinorrhea, and conjunctival injection. Sometimes, cluster headaches also present with Horner syndrome. These are more common in males. For acute treatment, we use sumatriptan or 100% oxygen. For prevention, the mainstay is verapamil. Trigeminal neuralgia. This condition features recurrent, brief episodes of very intense unilateral pain in the distribution of the trigeminal nerve, usually the maxillary V2 or mandibular V3 divisions. The most common cause is compression of the trigeminal nerve root by an aberrant vascular loop. The pain is described as electric shock, like or stabbing, and it usually lasts just seconds. It's often triggered by things as simple as light touch on the face, chewing, or talking. Treatment is with carbamazepine or oxcarbazepine. Dyskinesias. Let's talk about abnormal movements, the dyskinesias. First up is akathisia. This is that feeling of restlessness with an intense urge to move. It can show up as a side effect of neuroleptic medications or even as part of Parkinson's disease treatment. Next is asterixis. This is the classic flapping motion you see when a patient extends their wrists. It's strongly associated with hepatic encephalopathy, Wilson disease, and other metabolic derangements. Then we have athetosis. These are slow, snake-like, writhing movements, especially noticeable in the fingers. The cause is a lesion to the basal ganglia. You'll often see it in Huntington disease. Now, chorea. These are sudden, jerky, purposeless movements. The word chorea actually comes from Greek for dancing. Like athetosis, it's caused by basal ganglia lesions. Chorea is seen in Huntington disease and also in acute rheumatic fever. That's synonym chorea. Moving on to dystonia. This is sustained, involuntary muscle contraction. It can look like writer's cramp, blepharospasm, which is forceful blinking, or torticollis, which is abnormal neck twisting. For treatment, botulinum toxin injections are commonly used. Next is essential tremor. This is a high-frequency tremor that shows up with sustained posture, like when the arms are outstretched. It gets worse with movement or anxiety. Essential tremor is often familial, and interestingly, many patients self-medicate with alcohol since it can temporarily reduce the tremor amplitude. For treatment, we use non-selective beta blockers like propranolol or barbiturates like primidone. Then there's intention tremor. This is that slow, zigzag motion that appears when someone points or extends toward a target. It's caused by cerebellar dysfunction. Now, resting tremor. This is an uncontrolled movement of the distal appendages, most noticeable in the hands. The tremor actually goes away with intentional movement. It's caused by lesions in the substantia nigra, and it occurs at rest. The classic example is the pill-rolling tremor of Parkinson's disease. Easy way to remember. When you park your car, it's at rest. Then we've got hemibolismus. This looks like sudden, wild flinging of one side of the body. It's caused by a lesion to the contralateral subthalamic nucleus, often due to a lacunar stroke. Remember, in hemibolismus, half the body is going ballistic. Next is myoclonus. These are sudden, brief, uncontrolled muscle contractions. Think jerks or hiccups. They're common in metabolic problems like renal or liver failure, and also in Creutzfeldt-Jakob disease. Finally, restless leg syndrome. This involves uncomfortable sensations in the legs that create an irresistible urge to move. It tends to come out during inactivity, especially in the evening or at night, and movement like walking gives temporary relief. Most cases are idiopathic, often with a genetic predisposition. But it can also be linked with iron deficiency, chronic kidney disease, or diabetes mellitus, especially with neuropathy. Treatment involves gabapentinoids or dopamine agonists. Neurodegenerative movement disorders. Let's start with Parkinson's disease. This condition is caused by loss of dopaminergic neurons in the substantia and nigra pars compacta, which you can even see as depigmentation in the midbrain. Symptoms usually show up after age 60, and you can remember them with a mnemonic trap. T stands for tremor, that classic pill-rolling tremor at rest. R is for rigidity, either cogwheel or lead pipe stiffness. A is for akinesia or bradykinesia, which you'll notice as a shuffling gait or small handwriting, called micrographia. And P is for postural instability, meaning a tendency to fall. Dementia often comes later in the disease. The affected neurons contain Lewy bodies, which are eosinophilic inclusions made of alpha-synuclein. A good way to remember this is Parkinsonuclein. There's also a related condition called progressive supranuclear palsy, which is a Parkinson plus syndrome. It shows the trap features, but adds vertical gaze, palsy, and cognitive dysfunction. On MRI of the midbrain, it's associated with the famous hummingbird sign. Now, on a Huntington disease, here we see loss of GABAergic neurons in the striatum. It's an autosomal dominant condition caused by a trinucleotide repeat expansion, CAG, repeated in the Huntington gene on chromosome 4. Think for letters on chromosome 4. This expansion creates a toxic gain of function. Symptoms usually appear between ages 30 and 50. Patients develop chorea and athetosis, along with aggression, depression, and dementia. Sometimes early on it's mistaken for substance use. The pathology shows atrophy of the caudate and putamen, with ex vacuo enlargement of the ventricles. Neurotransmitter changes include increased dopamine, but decreased GABA and acetylcholine. Neuronal death happens via NMDA receptor binding and glutamate excitotoxicity. And because it's a trinucleotide repeat disorder, anticipation occurs. The CAG repeats expand in successive generations. Remember it this way. The caudate loses acetylcholine and GABA. Now let's touch on dementia. Dementia means a decline in cognitive ability, like memory or executive function, while consciousness stays intact. Some causes are reversible, for example depression, which is called pseudodementia, hypothyroidism, vitamin B12 deficiency, neurosyphilis, or normal pressure hydrocephalus. The most common cause is Alzheimer's disease, especially in older adults. Advanced age is the biggest risk factor. Patients with Down syndrome are also at higher risk for early-onset Alzheimer's disease because the amyloid precursor protein, AP, is located on chromosome 21. In Alzheimer's, acetylcholine levels in the brain go down. Now, let's talk about the proteins involved. APO2 decreases the risk of the sporadic form. You can remember it as protutive. APO4 increases the risk of the sporadic form. Think for Alzheimer's disease. And mutations in AP, presenilin 1 and presenilin 2 cause familial forms, which make up about 10% of cases and usually present earlier. On imaging and pathology, you see widespread cortical atrophy, especially in the hippocampi, with narrowing of the gyri and widening of the sulci. Microscopically, you'll find senile plaques in the gray matter. These are extracellular deposits of amyloid beta protein. They can also lead to amyloid angiopathy, which increases the risk of intraparenchymal hemorrhage. Amyloid beta itself comes from cleavage of AP. You'll also find neurofibrillary tangles, which are made of hyperphosphorylated tau protein. These tangles are insoluble cytoskeletal elements, and the number of tangles correlates directly with the degree of dementia. Another finding is Hirano bodies, which are intracellular eosinophilic rod-like inclusions, seen especially in the hippocampus. Dementia continued. Next up is frontotemporal dementia, which was formerly called Pick disease. This one starts with early changes in personality and behavior, known as the behavioral variant, or with aphasia, known as primary progressive aphasia. Sometimes it comes with associated movement disorders too. On imaging, you'll see frontal and temporal lobe atrophy. Microscopically, you can find inclusions of hyperphosphorylated tau. These are the classic round pick bodies, or inclusions of ubiquitinated TDP-43 protein. Now, let's move to Lewy body dementia. This condition is famous for visual hallucinations. You can even remember it as hallucinations. Patients showed dementia with fluctuating cognition and alertness, rapid eye movement sleep behavior disorder, and Parkinsonism. The pathology shows intracellular Lewy bodies, primarily in the cortex. And here's the key. If the cognitive symptoms and motor symptoms occur less than 1 year apart, it's called Lewy body dementia. If the motor symptoms clearly come first and the cognitive decline develops more than a year later, then it's considered dementia secondary to Parkinson's disease. The next big one is vascular dementia, which is actually the second most common cause of dementia in older adults. This happens because of multiple arterial infarcts or chronic ischemia. The clinical picture is a stepwise decline in cognitive function, with memory impairment that tends to show up later on. If you look at MRI or CT, you'll see multiple cortical and subcortical infarcts. Now, let's cover the infectious causes. First, Creutzfeldt-Jakob disease. This is a rapidly progressive dementia that unfolds over weeks to months, and it's often fatal. Patients present with myoclonus, especially a startle myoclonus and ataxia. The culprit is a prion protein. The normal PRPC converts into the abnormal PRPSC form, which is a beta-pleated sheet that resists protease digestion. Most cases are sporadic, but it can be transmitted through contaminated materials like corneal transplants or neurosurgical instruments. Pathology shows a spongiform cortex, which means vacuoles in the tissue without inflammation. On EEG, you'll often see periodic sharp wave complexes, and in the cerebrospinal fluid, the marker protein 14-3-3 may be elevated. Finally, we have HIV-associated dementia. This is a subcortical dementia seen in advanced HIV infection. It's characterized by cognitive deficits, gait disturbance, irritability, and depressed mood. Pathology shows diffuse gray matter and subcortical atrophy, with microglial nodules and multinucleated giant cells. Let's talk about idiopathic intracranial hypertension, also called pseudotumor cerebri. This is when intracranial pressure goes up, but there are no obvious structural findings on imaging. The big risk factors? Think of the mnemonic female toad. Tetracyclines, obesity, vitamin A excess, danazol, and of course female sex. It's also associated with dural venous sinus stenosis. Now, what do patients feel? They'll complain of headaches that get worse when lying down, tinnitus, and double vision, usually from a cranial nerve 6 palsy. But here's the key, there's no change in mental status. On eye exam, there's impaired optic nerve axoplasmic flow, which leads to papilledema. Visual field testing often shows an enlarged blind spot and peripheral constriction. If you do a lumbar puncture, it shows increased opening pressure, and interestingly, removing cerebrospinal fluid actually provides temporary headache relief. Treatment starts with weight loss and acetazolamide. In refractory cases, invasive procedures like cerebrospinal fluid shunt placement or optic nerve sheath fenestration surgery, if there's visual loss, can be used. Now let's zoom out and talk hydrocephalus. That's when cerebrospinal fluid volume goes up, leading to ventricular dilation, sometimes with increased intracranial pressure, sometimes not. There are a few types. Communicating hydrocephalus happens when cerebrospinal fluid absorption by the arachnoid granulations is impaired. A classic example is arachnoid scarring after meningitis. This leads to increased intracranial pressure, papilledema, and eventually herniation. Importantly, in communicating hydrocephalus, all the ventricles are dilated. Next is normal pressure hydrocephalus. This usually affects older adults, and it's idiopathic. Cerebrospinal fluid pressure isn't constantly high. It's elevated only episodically, and it doesn't actually increase the subarachnoid space volume. Instead, expansion of the ventricles stretches the fibers of the corona radiata. That leads to a triad that's easy to remember: wobbly, wacky, and wet. Wobbly equals gait apraxia, that magnetic gait. Wacky equals cognitive dysfunction. Wet equals urinary incontinence. Treatment is cerebrospinal fluid drainage, either through lumbar puncture or shunt placement. Then there's non-communicating hydrocephalus, also called obstructive hydrocephalus. This is caused by a structural blockage of cerebrospinal fluid flow within the ventricular system. Examples include stenosis of the aqueduct of Sylvius, a colloid cyst blocking the foramen of Monro, or a tumor. In this case, only the ventricles upstream of the blockage get dilated. And finally, hydrocephalus mimics. A classic example is ex vacuo ventriculomegaly. On imaging, it looks like there's more cerebrospinal fluid, but in reality, it's just the appearance caused by loss of brain tissue in neuronal atrophy. This is seen in conditions like Alzheimer's disease, HIV, frontotemporal dementia, and Huntington disease. And here's the key. In ex vacuo ventriculomegaly, intracranial pressure is normal, and that classic normal pressure hydrocephalus triad, wobbly, wacky, and wet, is not present. Multiple sclerosis. Multiple sclerosis is an autoimmune condition where the immune system attacks the central nervous system, that's the brain and spinal cord, causing inflammation and demyelination, followed by axonal damage. It most often affects females between the ages of 20 and 40. There's also a higher prevalence in people who grew up farther from the equator and in those with low vitamin D levels. Now, the presentation can vary a lot, but here are the classic scenarios. Optic neuritis, that's acute, painful, monocular vision loss, often with a relative afferent pupillary defect. Brainstem or cerebellar syndromes, things like double vision, ataxia, vertigo, scanning speech, dysarthria, intention tremor, nystagmus, or internuclear ophthalmoplegia. And that's usually bilateral, but sometimes unilateral. Pyramidal tract demyelination, which leads to weakness and spasticity. Spinal cord syndromes, such as Lermite sign, where neck flexion triggers an electric shock like sensation that shoots down the spine. Also neurogenic bladder, paraparesis, or sensory changes affecting the trunk or limbs. Symptoms can flare up or worsen when the body is stressed, like during heat exposure, that's called Uthoff phenomenon, exercise, or infection. The most common course is relapsing and remitting, where symptoms come and go over time. Now let's talk findings. In cerebrospinal fluid, you'll see increased immunoglobulin G levels and myelin basic protein. Oligoclonal bands in the CSF are a strong diagnostic clue. The gold standard test is MRI, which shows periventricular plaques. These are areas of oligodendrocyte loss and reactive gliosis. And importantly, multiple white matter lesions are disseminated in both space and time. For treatment, to stop relapses and slow disease progression, we use disease-modifying therapies like beta-interferon, glatiramer, and natalizumab. For acute flares, intravenous steroids are the go-to. Symptom management also matters. For neurogenic bladder, you can use muscarinic antagonists or botulinum toxin injections. For spasticity, baclofen, which is a GABA B receptor agonist, is effective. And for pain, tricyclic antidepressants or anticonvulsants can help. Other demyelinating and dysmyelinating disorders. Let's start with osmotic demyelination syndrome, also known as central pontine myelinolysis. This happens when there's massive axonal demyelination in the white matter of the pons, usually secondary to rapid osmotic changes. The most common culprit is iatrogenic, correcting low sodium too quickly, but it can also happen with rapid shifts of other osmolytes like glucose. Clinically, it presents with acute paralysis, difficulty speaking, trouble swallowing, double vision, and even loss of consciousness. You can also see altered mental status. Here's the rule of thumb. Correcting sodium from low to high, your pons will die. That's osmotic demyelination syndrome. Correcting sodium from high to low, your brain will blow. That's cerebral edema and herniation. Next, acute inflammatory demyelinating polyneuropathy, the most common subtype of Guillain-Barré syndrome. This is an autoimmune condition where the immune system attacks Schwann cells, leading to inflammation and demyelination of motor fibers, sensory fibers, and peripheral nerves, including cranial nerves 3 through 12. It's probably driven by molecular mimicry and can be triggered by vaccines or stress. It's often associated with infections like Campylobacter jejuni or viruses such as Zika. But interestingly, no single pathogen has been proven as the direct cause. The hallmark is symmetric, ascending muscle weakness or paralysis that starts in the legs. Reflexes are depressed or absent. You can also see bilateral facial paralysis and, in severe cases, respiratory failure. Autonomic issues are common too. Things like irregular heartbeat, swings in blood pressure, or abnormal sweating. Some patients also develop sensory changes. The prognosis is generally good, with most patients surviving and making a solid functional recovery. In the lab, cerebrospinal fluid shows increased protein with a normal cell count. That's called albuminocytologic dissociation. Treatment focuses first on respiratory support, which is absolutely critical. For disease-modifying therapy, either plasma exchange or intravenous immunoglobulins can be used. And note, steroids are not helpful here. Now on to acute disseminated post-infectious encephalomyelitis. This is a multifocal inflammatory and demyelinating condition that happens after an infection or sometimes after vaccination. Patients present with rapidly progressive, multifocal neurological symptoms along with altered mental status. Then we got Charcot-Marie tooth disease. This is also called hereditary motor and sensory neuropathy. It's actually a group of progressive, inherited nerve disorders caused by defective proteins that normally support the structure and function of peripheral nerves or their myelin sheath. Most cases are autosomal dominant. Classic features include foot deformities like pes cavis or hammer toes, weakness in the lower extremities, especially foot drop, and sensory deficits like reduced vibration sense and proprioception. The most common type is CMT1A, which results from a PMP22 gene duplication. Easy way to remember, CMT can't move toes. Next is progressive multifocal leukoencephalopathy. This is a demyelinating disease of the central nervous system caused by destruction of oligodendrocytes, usually because of reactivation of latent JC virus infection. It's strongly linked to severe immunosuppression, think lymphomas, leukemias, AIDS, or organ transplantation. Clinically, it's rapidly progressive and usually fatal. It often involves the parietal and occipital lobes, so visual symptoms are very common. The risk is particularly high in patients on immunosuppressive medications like natalizumab. Another one is critical illness polyneuropathy. Here, there's axonal degeneration, probably driven by inflammatory mediators and microcirculation injury. This leads to impaired nerve excitability, partly because sodium channels get inactivated. The result is symmetric weakness that tends to be worse proximally than distally. Deep tendon reflexes are reduced, and weakness of the diaphragm can make it hard for patients to come off mechanical ventilation. Finally, there are other dysmyelinating disorders worth noting. Crab disease, metachromatic leukodystrophy, adrenoleukodystrophy. These are all inherited leukodystrophies where abnormal myelin metabolism leads to progressive neurologic dysfunction. Neurocutaneous disorders. All right, let's dive into the neurocutaneous disorders. These are conditions where genetic mutations cause both neurologic and skin-related findings. Think of them as syndromes that connect the brain, nerves, and skin, often with tumors or vascular malformations. First up is Sturge-Weber syndrome. This is a congenital, non-hereditary anomaly of neural crest derivatives. It happens because of somatic mosaicism from an activating mutation in one copy of the GNAQ gene. The classic presentation includes a port wine stain, also called a nevus flammeus. This is a capillary vascular malformation that shows up as a non-neoplastic birthmark in the distribution of CNV1 or V2. On top of that, patients can have an ipsilateral leptomeningeal angioma, which often calcifies. That can cause seizures, epilepsy, and intellectual disability. Add to that an episcleral hemangioma, which increases intraocular pressure and can lead to early-onset glaucoma. This condition is also known as encephalotrigeminal angiomatosis. Next, tuberous sclerosis complex. This is autosomal dominant with variable expression. The mutations happen in tumor suppressor genes, TSC1 on chromosome 9, which encodes Hamerton, or TSC2 on chromosome 16, which encodes tuberin, or as some say, tuberin. Clinically, there are hamartomas in the CNS and skin, angiofibromas, mitral regurgitation, ash leaf spots on the skin, cardiac rhabdomyomas, intellectual disability, renal angiomylopomas, seizures, and Sjagren patches. There's also an increased risk of subependymal giant cell astrocytomas and umbral fibromas. Then we have neurofibromatosis type 1, also known as von Recklinghausen disease. This is autosomal dominant with complete penetrance. The mutation occurs in the NF1 tumor suppressor gene on chromosome 17. This gene encodes neurofibromin, a negative regulator of RAS. The clinical features can be remembered with the mnemonic cyclops: café au lait spots, intellectual disability, cutaneous neurofibromas, Lisch nodules, those are pigmented iris hamartomas, optic gliomas, pheochromocytomas, seizures or focal neurologic signs, often due to meningiomas, and skeletal findings like sphenoid dysplasia or other bone lesions. Here's an easy way to recall. The name von Recklinghausen has 17 letters, which matches chromosome 17. Now, neurofibromatosis type 2. This is also autosomal dominant, but here the mutation is in the NF2 tumor suppressor gene on chromosome 22. The gene encodes Merlin, a tumor suppressor. The hallmark is bilateral vestibular schwannomas. Patients may also have juvenile cataracts, meningiomas, and ependymomas. Quick trick to remember: NF2 affects 2 ears and 2 eyes. Finally, von Hippel-Lindau disease. This one is autosomal dominant, caused by deletion of the VCHL gene on chromosome 3p. Normally, PVCHL helps ubiquitinate hypoxia-inducible factor 1 alpha, tagging it for degradation. When this system fails, tumors can develop. The classic findings include hemangioblastomas, which are highly vascular tumors with hyperchromatic nuclei in the retina, brainstem, cerebellum, and spinal cord. There can also be angiomatosis, bilateral renal cell carcinomas, and pheochromocytomas. The mnemonic is HARP: hemangioblastomas, angiomatosis, renal cell carcinoma, pheochromocytoma. Don't forget, VHL is linked with numerous tumors, benign and malignant. And here's another way to keep it straight. VHL has 3 letters, and it's on chromosome 3. It's also associated with RCC, renal cell carcinoma, which also has 3 letters. Adult primary brain tumors. Glioblastoma is the most common and highly malignant primary brain tumor, with about a 1-year median survival. It is typically found in the cerebral hemispheres and can cross the corpus callosum, producing what is called a butterfly glioma. It is associated with EGFR amplification. Histologically, it arises from astrocytes and is GFAP positive. Tumor cells show pseudo-palisading pleomorphic arrangements bordering central areas of necrosis, hemorrhage, and microvascular proliferation. Oligodendroglioma is relatively rare and slow-growing, most often found in the frontal lobes. It is often calcified. It originates from oligodendrocytes. The characteristic histology shows fried egg cells, which are round nuclei with clear cytoplasm and a chicken wire capillary pattern. Meningioma is a common and typically benign tumor, occurring more often in females than males. It arises along the surface of the brain or spinal cord. It is extraaxial, meaning external to the brain parenchyma, and may have a dural attachment that appears as a dural tail. It is usually well circumscribed, with a spherical or lobular shape. Meningiomas are often asymptomatic but may present with seizures or focal neurologic signs. Treatment includes resection and radiosurgery. The tumor originates from arachnoid cells. Histology shows spindle cells concentrically arranged in a whorled pattern and psammoma bodies, which are laminated calcifications. Hemangioblastoma most often occurs in the cerebellum. It is associated with von Hippel-Lindau syndrome when found with retinal angiomas. These tumors can produce erythropoietin, leading to secondary polycythemia. They originate from blood vessels, and histology shows closely arranged, thin-walled capillaries with minimal intervening parenchyma. Pituitary adenoma may be non-functioning, or it may be hormone-producing. Non-functional tumors typically present with mass effects, such as bitemporal hemianopia due to pressure on the optic chiasm. Pituitary apoplexy may result in hypopituitarism. The classic functional type is prolactinoma, which presents in females as galactorrhea, amenorrhea, and decreased bone density due to suppression of estrogen. In males, it may present as decreased libido and infertility. Treatment includes dopamine agonists such as bromocriptine or cabergoline or transsphenoidal resection. Pituitary adenomas represent hyperplasia of only one type of endocrine cell in the pituitary. Most commonly, they arise from lactotrophs, causing hyperprolactinemia. Less commonly, they arise from somatotrophs, leading to acromegaly or gigantism, or from corticotrophs, leading to Cushing disease. Rarely, they come from thyrotrophs or gonadotrophs, leading to TSH, FSH, or LH-excess. Schwannoma classically arises at the cerebellopontine angle. It is benign and involves cranial nerves 5, 7, and 8, but can occur along any peripheral nerve. It is often localized to cranial nerve 8 in the internal acoustic meatus, where it produces vestibular schwannoma. This can present with hearing loss, tinnitus, and unsteady gait. Bilateral vestibular schwannomas are a hallmark of neurofibromatosis type 2. Treatment includes resection or stereotactic radiosurgery. Histology shows a Schwann cell origin, positive for S100. Microscopically, they are biphasic with dense hypercellular spindle cell areas alternating with hypocellular myxoid areas. This image is the continuation of adult primary brain tumors and shows radiologic and histologic findings. Let me walk you through each labeled panel, A to L, and connect them to the tumors. Glioblastoma. A. MRI showing a ring-enhancing lesion with central necrosis, classic for glioblastoma. B. Histology shows pseudopalisading tumor cells around necrosis. Oligodendroglioma. C. MRI of a frontal lobe lesion, typical site. D. Histology shows fried egg cells, round nuclei with clear cytoplasm. Meningioma. E. MRI showing extraaxial mass with a dural tail. F. Histology with whorled spindle cells and psammoma bodies. Hemangioblastoma. G. MRI of a cerebellar lesion. H. Histology showing numerous thin-walled capillaries with little parenchyma. Pituitary adenoma. I. Visual field defect diagram, bitemporal hemianopia, loss of temporal vision fields. J. MRI showing a pituitary mass compressing the optic chiasm. Schwannoma. K. MRI showing bilateral vestibular schwannomas at the cerebellopontine angle, seen in NF2. L. Histology showing biphasic pattern of spindle cells with hypercellular and hypocellular areas. Childhood primary brain tumors. Pilocytic astrocytoma is the most common primary brain tumor in childhood. It is usually well circumscribed. In children, it is most often found in the posterior fossa, such as the cerebellum, but it can also be supratentorial. It often has a cystic appearance with a mural nodule. It arises from astrocytes and is GFAP positive. Histology shows bipolar neoplastic cells with hair-like projections associated with microcysts and Rosenthal fibers, which are eosinophilic corkscrew-shaped fibers. Pilocytic astrocytoma is benign and has a good prognosis. Medulloblastoma is the most common malignant brain tumor in childhood. It commonly involves the cerebellum, often affecting the vermis. Children may present with truncal ataxia. It can compress the fourth ventricle, causing non-communicating hydrocephalus, headaches, and papilledema. Medulloblastoma is a form of primitive neuroectodermal tumor, or PNET. Histology shows homerite rosettes, which are small round blue cells surrounding a central area of neuropil. These tumors are synaptophysin positive. Medulloblastoma can spread to the spinal cord via drop metastases. Ependymoma most commonly arises in the fourth ventricle and can lead to non-communicating hydrocephalus. It generally has a poor prognosis. It originates from ependymal cells. Histology shows characteristic perivascular pseudorosets. Rod-shaped blepharoplasts, which are basal ciliary bodies, may be found near the nucleus. Craniopharyngioma is the most common childhood supratentorial tumor. Calcification is common. It usually arises along the pituitary stalk, where it may compress the optic chiasm, leading to bitemporal hemianopia. Because of this, it may be confused with a pituitary adenoma. It is associated with a high recurrence rate. Craniopharyngioma is derived from remnants of Rathke's pouch, which comes from ectoderm. Histology shows anucleate squamous cells, also called ghost cells, forming keratinous nodules with dystrophic calcifications. Cholesterol crystals may also be found in a motor oil, like fluid within the tumor. Pineal gland tumors are most commonly extragonadal germ cell tumors, with a higher incidence in males. They may present with non-communicating hydrocephalus due to compression of the cerebral aqueduct and with Parnot syndrome due to compression of the dorsal midbrain. Parnot syndrome is characterized by the triad of upward gaze palsy, convergence retraction nystagmus, and light near dissociation. Histologically, these tumors are similar to testicular seminomas. Herniation syndromes. Cingulate herniation, also called subfalcine herniation, occurs when brain tissue is pushed onto the falx cerebri. This can cause compression of the anterior cerebral artery, leading to contralateral lower extremity weakness. If the dominant hemisphere is affected, compression of the arcuate fasciculus may result in aphasia. Central, or downward transtentorial herniation, causes caudal displacement of the brainstem. This leads to rupture of the paramedian basilar artery branches, producing durate hemorrhages. This type of herniation is usually fatal. Uncal herniation involves the uncus, which is the medial temporal lobe. Early signs include an ipsilateral blown pupil due to unilateral compression of cranial nerve 3 and contralateral hemiparesis. As the herniation progresses, late findings include coma and Kernahan phenomenon. Kernahan phenomenon is misleading because it produces ipsilateral hemiparesis and sometimes contralateral blown pupil due to compression of the contralateral cerebral peduncle and cranial nerve 3 against the Kernahan notch. Cerebellar tonsillar herniation occurs when the cerebellar tonsils are pushed into the foramen magnum. This compresses the brainstem, leading to coma and death. Motor neuron signs. Now, let's look at the specific signs in detail. First sign, weakness. Weakness, or paresis, can be present in both upper and lower motor neuron lesions. So, while it tells us there is a problem, it doesn't differentiate between the two. Atrophy. Atrophy refers to the wasting away or loss of muscle mass. In an upper motor neuron lesion, atrophy is typically not present. In a lower motor neuron lesion, atrophy is present. This is because the nerve connection directly to the muscle is lost. Fasciculations. Fasciculations are small, involuntary muscle twitches or ripples under the skin. They are not seen in an upper motor neuron lesion. They are seen in a lower motor neuron lesion. A quick note, fasciculations are essentially the muscle twitching as it loses its nerve supply. Reflexes. This refers to deep tendon reflexes like the knee-jerk reflex. In an upper motor neuron lesion, reflexes are increased or hyperactive. In a lower motor neuron lesion, reflexes are decreased or absent. Tone. Muscle tone is the muscle's resistance to passive stretch. In an upper motor neuron lesion, tone is increased. This is often called hypertonia. In a lower motor neuron lesion, tone is decreased, a state known as hypotonia or flaccidity. The Babinski sign. This is a test where the sole of the foot is stroked. In an upper motor neuron lesion, the Babinski sign is positive, meaning the big toe extends upward and the other toes fan out. In a lower motor neuron lesion, the Babinski sign is negative, meaning a normal downward curl of the toes. It's important to know that a positive Babinski is normal in infants until the nervous system matures. Spastic paresis. This is a specific type of weakness characterized by increased tone and reflexes. It is present in an upper motor neuron lesion. It is not present in a lower motor neuron lesion. Flaccid paralysis. This is a complete loss of muscle strength accompanied by low tone and absent reflexes. It is not a feature of an upper motor neuron lesion. It is a key feature of a lower motor neuron lesion. Finally, clasp knife spasticity. This is a specific phenomenon where initial resistance to moving a joint is suddenly followed by a release, like the blade of a clasp knife snapping shut. It is present in an upper motor neuron lesion. It is not present in a lower motor neuron lesion. Comments. Lower motor neuron equals everything lowered, including muscle mass, tone, reflexes, and toes. Upper motor neuron equals everything up, including tone, reflexes, and toes. Spinal cord lesions. Poliomyelitis involves destruction of the anterior horns by poliovirus. Transmission is fecal-oral. The virus replicates in lymphoid tissue of the oropharynx and small intestine, then spreads to the central nervous system via the bloodstream. It causes acute lower motor neuron signs with asymmetric weakness, along with symptoms of viral meningitis, such as fever, headache, and neck stiffness. Respiratory muscle involvement can lead to respiratory failure. Cerebrospinal fluid shows increased white blood cells, especially lymphocytes, and a slight increase of protein, with no change in glucose. Poliovirus can be isolated from stool or throat secretions. Spinal muscular atrophy is a congenital degeneration of the anterior horns. It is caused by an autosomal recessive mutation in the SMN1 gene, which encodes survival motor neuron protein. This leads to defective SNRNP assembly and lower motor neuron apoptosis. The most common type is spinal muscular atrophy type 1, also called Verdnig-Hoffmann disease. It presents with only lower motor neuron signs, including symmetric weakness. Affected infants are described as floppy babies with marked hypotonia, flaccid paralysis, and tongue fasciculations. Amyotrophic lateral sclerosis, or ALS, is a combined upper motor neuron and lower motor neuron degeneration affecting the corticospinal and corticobulbar tracts, as well as the brainstem and spinal cord. It is usually idiopathic, but familial cases may be linked to mutations in SOD1, which encodes superoxide dismutase 1. ALS is also called Lou Gehrig disease. Lower motor neuron signs include flaccid limb weakness, fasciculations, atrophy, and bulbar palsy with dysarthria, dysphagia, and tongue atrophy. Upper motor neuron signs include spastic limb weakness, hyperreflexia, clonus, and pseudobulbar palsy, which is characterized by dysarthria, dysphagia, and emotional lability. Importantly, ALS has no sensory or bowel and bladder deficits. It is a fatal disease, most often due to respiratory failure. Treatment includes riluzole, remembered as riluzole, and edaravone, a free radical scavenger, both of which slow functional decline. Tabes dorsalis is degeneration and demyelination of the dorsal columns and dorsal roots caused by treponema pallidum in tertiary syphilis. It produces progressive sensory ataxia due to impaired proprioception and poor coordination. Examination shows a positive Romberg sign and absent deep tendon reflexes. It is associated with shooting pain, Argyll-Robertson pupils, and Charcot joints. Subacute combined degeneration results from vitamin B12 deficiency. It causes demyelination of the spinocerebellar tracts, the lateral corticospinal tracts, and the dorsal columns. The clinical triad includes ataxic gait, paresthesias, and impaired position and vibration sense, often with a positive Romberg sign. Upper motor neuron signs are also present. Anterior spinal artery occlusion causes spinal cord infarction, sparing the dorsal horns and dorsal columns. The watershed area is the mid-thoracic anterior spinal artery territory, since the artery of Adamkiewicz supplies the anterior spinal artery below T8. Causes include aortic aneurysm repair. Clinically, there are upper motor neuron signs below the lesion due to corticospinal tract involvement. Lower motor neuron signs at the level of the lesion due to anterior horn involvement, and loss of pain and temperature sensation below the lesion due to spinothalamic tract involvement. Brown-Sequard syndrome. Brown-Sequard syndrome results from hemisection of the spinal cord. The findings are due to deficits in multiple pathways. At the level of the lesion, there is ipsilateral loss of all sensation and ipsilateral lower motor neuron signs, such as flaccid paralysis. Below the level of the lesion, there are ipsilateral upper motor neuron signs due to corticospinal tract involvement. The dorsal columns are also affected, leading to ipsilateral loss of proprioception, vibration, and fine two-point discriminatory touch below the lesion. Meanwhile, the spinothalamic tract is affected contralaterally, causing loss of pain, temperature, and crude, non-discriminative touch below the lesion. If the lesion occurs above T1, the oculosympathetic pathway is disrupted, leading to ipsilateral Horner syndrome, which presents as ptosis, meiosis, and anhidrosis. Friedreich ataxia. Friedreich ataxia is an autosomal recessive trinucleotide repeat disorder, with GAA repeats on chromosome 9. It affects the frataxin gene, which encodes an iron-binding protein. Loss of frataxin function leads to mitochondrial impairment. The condition causes degeneration of several spinal cord tracts, the lateral corticospinal tract, producing spastic paralysis. The spinocerebellar tract, producing ataxia. The dorsal columns, producing loss of vibration and proprioception, and the dorsal root ganglia, producing loss of deep tendon reflexes. Clinical features include a staggering gait, frequent falling, nystagmus, dysarthria, pes cavus, hammer toes, diabetes mellitus, and hypertrophic cardiomyopathy, which is the most common cause of death. Presentation is usually in childhood and may include kyphoscoliosis. A helpful memory aid is Friedreich is fantastic. He's your favorite frat brother, always staggering and falling, but with a sweet, big heart. The word fantastic reminds you of frataxin, and ataxic gait reminds you of the GAA trinucleotide repeat. Cerebral palsy. Cerebral palsy is a permanent motor dysfunction caused by a non-progressive injury to the developing fetal or infant brain. It is the most common movement disorder in children. The etiology is multifactorial. Prematurity and low birth weight are the strongest risk factors. Cerebral palsy is associated with the development of periventricular leukomalacia, which is focal necrosis of white matter tracts. Clinically, it presents with upper motor neuron signs, such as spasticity and hyperreflexia, affecting one or more limbs. Other features include persistence of primitive reflexes, abnormal posture, developmental delays in motor skills, and neurobehavioral abnormalities, such as excessive docility or irritability. Treatment options include muscle relaxants such as baclofen, botulinum toxin injections, and selective dorsal rhizotomy. Prevention includes administration of prenatal magnesium sulfate in high-risk pregnancies, which reduces the incidence and severity of cerebral palsy. Common cranial nerve lesions. Cranial nerve, 5-motor lesion. Injury to the motor component of the trigeminal nerve causes the jaw to deviate toward the side of the lesion. This happens because of the unopposed force from the opposite pterygoid muscle. Cranial nerve 10 lesion. Injury to the vagus nerve causes the uvula to deviate away from the side of the lesion. The weak side collapses, so the uvula points away. Cranial nerve 11 lesion. Damage to the spinal accessory nerve causes weakness in turning the head away from the side of the lesion due to sternocleidomastoid weakness, and shoulder droop on the side of the lesion due to trapezius weakness. Cranial nerve 12 lesion. A lower motor neuron lesion of the hypoglossal nerve causes the tongue to deviate toward the side of the lesion. This is remembered by the phrase, lick your wounds. Facial nerve lesions. Bell palsy. The most common cause of peripheral facial palsy is Bell palsy. It usually develops after HSV reactivation. Treatment includes glucocorticoids with or without acyclovir. Most patients gradually recover function, but aberrant regeneration can occur. Other causes of peripheral facial palsy include Lyme disease, herpes zoster, Ramsay-Hunt syndrome, which is the triad of ipsilateral facial paralysis, otalgia, and vesicles near the auditory canal, sarcoidosis, tumors such as parotid gland tumors, and diabetes mellitus. Facial nerve lesions, UMN versus LMN. Upper motor neuron lesion. The lesion is in the motor cortex or the corticobulbar tract before it reaches the facial nucleus. The deficit is contralateral, and it affects only the lower muscles of facial expression. The forehead is spared because it receives bilateral innervation. Other symptoms variable, depends on size of lesion. Lower motor neuron lesion. The lesion is at the facial nucleus itself or anywhere along cranial nerve 7. The deficit is ipsilateral, and it affects both the upper and lower muscles of facial expression. Additional symptoms include incomplete eye closure leading to dry eyes and corneal ulceration, hyperacusis, and loss of taste sensation from the anterior tongue. The forehead is involved in LMN lesions, unlike human lesions. Now let's move to neurology, otology, and talk about auditory anatomy and physiology. The outer ear is the visible portion of the ear, also called the pinna. It includes the auditory canal and the tympanic membrane. Its job is to transfer sound waves via vibration of the tympanic membrane. The middle ear is an air-filled space with three bones called the ossicles, the malleus, incus, and stapes. The ossicles conduct and amplify sound from the tympanic membrane to the inner ear. The inner ear is a snail-shaped, fluid-filled cochlea. It contains the basilar membrane, which vibrates secondary to sound waves. That vibration is then transduced via specialized hair cells into auditory nerve signaling to the brainstem. Each frequency leads to vibration at a specific location on the basilar membrane, a property called tonotopy. Low frequency is heard at the apex near the helicotrema, where the membrane is wide and flexible. High frequency is heard best at the base of the cochlea, where the membrane is thin and rigid. Otitis externa. Otitis externa is inflammation of the external auditory canal. It is most commonly due to Pseudomonas. It is associated with water exposure, known as swimmer's ear, and with ear canal trauma or occlusion, for example from hearing aids. It presents with otalgia that worsens with ear manipulation, pruritus, hearing loss, and discharge. A severe form, called malignant or necrotizing otitis externa, is an invasive infection causing osteomyelitis. This is a complication of otitis externa, mostly seen in older patients with diabetes. It presents with severe otalgia and otorrhea and may lead to cranial nerve palsies. On physical exam, there is granulation tissue in the ear canal. Otitis media. Otitis media is inflammation of the middle ear. It is most commonly due to non-typable Streptococcus pneumoniae, Haemophilus influenza, and Moraxella catarrhalis. It is associated with eustachian tube dysfunction, which promotes overgrowth of bacterial colonizers of the upper respiratory tract. It is usually seen in children under 2 years old. It presents with fever, otalgia, and hearing loss. On physical exam, there is a bulging erythematous tympanic membrane that may rupture. A complication of acute otitis media is mastoiditis, which is infection of the mastoid process of the temporal bone. This occurs because of continuity of the middle ear cavity with the mastoid air cells. Mastoiditis presents with postauricular pain, erythema, and swelling, and may lead to brain abscess. Common causes of hearing loss. Noise-induced hearing loss happens due to damage to the stereociliated cells in the organ of Corti. The very first loss is of high-frequency hearing. A sudden, extremely loud noise can also produce hearing loss because of tympanic membrane rupture. Presbycusis is aging-related progressive, bilateral, and symmetric sensorineural hearing loss, most often of the higher frequencies. This occurs due to destruction of hair cells at the cochlear base, while low-frequency hearing at the apex is preserved. Diagnosing hearing loss. We use two main tests, the Weber test and the Rinne test. For the Weber test, a tuning fork is placed on the vertex of the skull. In normal hearing, there's no localization. In conductive hearing loss, the sound localizes to the affected ear because of decreased transmission of background noise. In sensorineural hearing loss, the sound localizes to the unaffected ear because of decreased transmission of all sound. For the Rinne test, the tuning fork is first placed in front of the ear to test air conduction, AC, and then on the mastoid process to test bone conduction, BC. In normal hearing, air conduction is better than bone conduction, so AC is greater than BC. In conductive hearing loss, bone conduction is better, so BC is greater than AC. In sensorineural hearing loss, air conduction is still greater than bone conduction, but both are reduced compared to normal. Cholesteatoma. A cholesteatoma is an abnormal growth of keratinized squamous epithelium in the middle ear, also called skin in the wrong place. It is usually acquired, but it can also be congenital. Primary acquired cholesteatoma results from tympanic membrane retraction pockets that form due to eustachian tube dysfunction. Secondary acquired cholesteatoma results from a tympanic membrane perforation, for example after otitis media, that allows squamous epithelium to migrate into the middle ear. It classically presents with painless otorrhea and may erode the ossicles, leading to conductive hearing loss. Vertigo. Vertigo is the sensation of spinning while actually stationary. It's a subtype of dizziness, but it's distinct from lightheadedness. Peripheral vertigo is more common than central vertigo. Peripheral vertigo is due to inner ear pathologies such as vestibular neuritis. Benign paroxysmal positional vertigo caused by semicircular canal debris, which leads to episodic vertigo lasting less than 1 minute, provoked by certain head movements. It's diagnosed with the Dix-Hallpike maneuver and treated with the Epley maneuver. Another cause is Meninges disease, which is due to endolymphatic hydrops, too much endolymph in the inner ear. The classic triad is vertigo, sensorineural hearing loss, and tinnitus. Think men wear vests. Findings in peripheral vertigo include mixed horizontal torsional nystagmus, never purely torsional or vertical. It does not change direction and is suppressible with visual fixation. Central vertigo is due to brainstem or cerebellar lesions, for example stroke affecting the vestibular nuclei, demyelinating disease, or a posterior fossa tumor. Findings here include nystagmus of any direction that is not suppressible with visual fixation, plus other neurologic findings such as diplopia, ataxia, or dysmetria. Now we move to neurology ophthalmology. Let's start with the normal anatomy of the eye. At the very center, we have the macula, which includes the fovea, the area of highest visual acuity. Surrounding structures include the ciliary body in the middle layer, which produces aqueous humor and helps control lens shape through the zonular fibers. At the very front, there's the cornea, part of the outer layer, which is the main refractive surface of the eye. Just behind it sits the iris, part of the middle layer, which controls the size of the pupil. The lens lies right behind the pupil, focusing light onto the retina. The eye has different chambers. The anterior chamber lies between the cornea and iris. The posterior chamber lies between the iris and the lens. Together, these form the anterior segment of the eye. Behind the lens, there's the vitreous chamber filled with vitreous humor, and this, along with the retina and optic structures, forms the posterior segment. In the outermost layer of the eye is the sclera, the tough white coat. The middle layer is the choroid, which supplies blood, and the innermost layer is the retina, which contains photoreceptors. At the back of the retina, you'll find the optic disc, the optic nerve, the central retinal artery, and the central retinal vein. Now let's move to conjunctivitis, commonly called red eye. This is inflammation of the conjunctiva, and it can have several causes. Allergic conjunctivitis, typically itchy, usually bilateral. Bacterial conjunctivitis causes a purulent discharge treated with antibiotics. Viral conjunctivitis, the most common cause, often due to adenovirus. It presents with a sparse mucus discharge, watery tearing or lacrimation, and sometimes swollen preauricular lymph nodes. It's self-limiting. There's also neonatal conjunctivitis, seen in newborns after vaginal birth. It presents with eyelid swelling and exudative discharge. We detect bacterial causes using nucleic acid amplification testing. Maternal prenatal screening and treatment are key to preventing it. The most common cause is chlamydia trachomatis, serotypes D through K. It typically appears 5 to 14 days after birth. Treatment is with erythromycin or azithromycin. Neisseria gonorrhoeae conjunctivitis typically appears earlier, about 2 to 5 days after birth. Prophylaxis is with erythromycin eye drops, but treatment requires ceftriaxone to prevent blindness. Other pathogens include herpes simplex virus and adenovirus. Next are refractive errors, which are a common cause of impaired vision. They are fully correctable with glasses. A little memory trick here: Meninges Hida Vex cylinders. That reminds us of myopia, hyperopia, and astigmatism. Myopia, or nearsightedness, is the most common error. Here, the eye is too long for the refractive power of the cornea and lens. As a result, light focuses in front of the retina. The correction is with a concave or diverging lens. Hyperopia, or farsightedness, is the opposite. The eye is too short for the refractive power, so light focuses behind the retina. The correction is with a convex or converging lens. Astigmatism is caused by irregular or asymmetric curvature of the cornea or lens, so light has different refractive power at different axes. This is corrected with a cylindrical lens. Lens disorders. With presbyopia, we see an aging-related impairment in accommodation. That's the ability to focus on near objects. The exact mechanism isn't fully understood, but it likely involves loss of lens elasticity as we age. That's why many people eventually need reading glasses or magnifiers. Then we have cataracts. A cataract is a painless, often bilateral opacification of a lens. Patients may notice glare, loss of the red reflex, and progressive vision loss, especially at night. There are many risk factors. Acquired risk factors include older age, tobacco use, alcohol overuse, excessive sunlight exposure, prolonged glucocorticoid use, diabetes mellitus, trauma, and infection. Congenital risk factors include genetic and metabolic conditions, such as classic galactosemia, galactokinase deficiency, trisomies 13, 18, and 21, torch infections like rubella, and systemic disorders such as Marfan syndrome, Alport syndrome, myotonic dystrophy, and neurofibromatosis type 2. The main treatment is surgical replacement of the lens with an artificial implant. Next is lens dislocation, also called ectopia lennis. This is when the lens is displaced or malpositioned. The most common cause is trauma, but it can also be seen in systemic diseases such as Marfan syndrome and homocystinuria. Now let's move on to the aqueous humor pathway, sometimes called the angle of the eye. Aqueous humor is produced by the non-pigmented epithelium of the ciliary body. Its flow and drainage are essential for maintaining intraocular pressure. There are two main pathways of outflow. 1. Trabecular outflow. This accounts for about 90% of drainage. Aqueous humor drains through the trabecular meshwork, then into the canal of Schlemm, and finally into the episcleral vasculature. Medications like muscarinic agonists, for example, carbachol and pilocarpine, can increase this outflow. 2. Uveoscleral outflow. This accounts for about 10% of drainage. Here, the fluid drains into the uvea and sclera. Prostaglandin agonists, such as latanoprost and bimatoprost, can increase this pathway. Meanwhile, aqueous humor production itself can be reduced using certain drugs. These include beta blockers like timolol, alpha-2 agonists like brimonidine, and carbonic anhydrase inhibitors such as acetazolamide. Altogether, aqueous humor is produced in the posterior chamber, flows through the pupil into the anterior chamber, and then drains out via trabecular or uveoscleral routes. Its balance between production and drainage determines intraocular pressure. Glaucoma. Glaucoma is an optic neuropathy, meaning it's damage to the optic nerve that leads to progressive vision loss. Typically, vision loss starts peripherally and then progresses toward the center. It's often, though not always, accompanied by increased intraocular pressure, or IOP. The cause is most often primary, meaning it arises without another disease driving it. But it can also be secondary, caused by something else, such as uveitis or prolonged use of glucocorticoids. When we look with funduscopy, the classic finding is optic disc cupping. Normally, the optic disc has a healthy outer rim. In glaucoma, this rim thins out and the cup, the central depression of the disc, becomes enlarged. Treatment for glaucoma focuses on lowering intraocular pressure, either through medications or surgical interventions. Now, let's look at the two major types. Open-angle glaucoma comes first. In this type, the anterior chamber angle is open, just like normal. This is actually the most common type in the United States. The problem is resistance to aqueous humor drainage through the trabecular meshwork. Risk factors include older age, black race, family history, and diabetes mellitus. The tricky part is that open-angle glaucoma is often silent. People usually have no symptoms, and it's often discovered only during routine eye exams. Treatment often starts with prostaglandin analogs or beta blockers to lower intraocular pressure. The other type is angle closure glaucoma. Here, the anterior chamber angle is narrowed or completely closed. This is usually linked to anatomical abnormalities, for example, the lens being pushed too far forward so it presses against the central iris. This blocks aqueous humor from flowing through the pupil. As pressure builds up in the posterior chamber, it pushes the iris forward against the cornea, blocking the drainage pathways at the angle. Angle closure glaucoma can develop gradually and silently. That's the chronic form. But can also occur suddenly in what's called acute angle closure glaucoma. In an acute attack, the pupil gets completely blocked, causing an abrupt closure of the angle and a rapid rise in intraocular pressure. Patients present dramatically, severe eye pain, conjunctival redness, sudden vision loss, halos around lights, a fixed mid-dilated pupil, headache, nausea, and vomiting. There's a classic phrase, "It hurts in a hurry," with halos, a headache, and a half-dilated pupil. Acute angle closure glaucoma is a true ophthalmic emergency. If not managed immediately, it can cause permanent blindness. Importantly, mydriatic agents, drugs that dilate the pupil, are contraindicated because they make the blockage worse. Treatment requires urgent lowering of intraocular pressure using a combination of medications like beta blockers, alpha-2 agonists, pilocarpine, acetazolamide, and mannitol. Retinal disorders. The retina is the delicate, light-sensitive layer at the back of the eye, and when it's damaged, the result is vision loss. Let's walk through the major retinal disorders one by one. First is age-related macular degeneration, or AMD. This is degeneration of the macula, the central area of the retina that's responsible for sharp vision. The hallmark symptom is loss of central vision, often described as blind spots or scotomas. There are two types. Dry AMD is the most common. It causes a gradual decline in vision. On exam, you'll see yellowish subretinal deposits called drusen. Wet AMD is less common, but more dangerous. It causes a rapid decline in vision, usually due to abnormal bleeding from choroidal neovascularization. An early symptom is metamorphopsia. Straight lines start to look wavy or distorted. Next is diabetic retinopathy, caused by chronic high blood sugar damaging retinal blood vessels. There are two main types. Non-proliferative diabetic retinopathy, which is the most common. You'll see microaneurysms, hemorrhages, cotton wool spots, and hard exudates. Vision loss here mainly comes from macular edema. Proliferative diabetic retinopathy, which is more severe. Chronic hypoxia stimulates new but fragile blood vessels to grow on the retina. These can bleed into the vitreous or pull on the retina, causing tractional retinal detachment. Hypertensive retinopathy comes from chronic high blood pressure. It causes spasm, thickening, and fibrinoid necrosis of retinal vessels. On funduscopy, you might see arteriovenous nicking, microaneurysms, hemorrhages, cotton wool spots, or hard exudates. When those exudates form in a star pattern around the macula, it's called a macular star. If you see papilledema in this setting, that's a hypertensive emergency, and it requires immediate blood pressure control. Retinal artery occlusion is a blockage of the central or a branch retinal artery, most often from an embolus, usually coming from carotid artery atherosclerosis or from the heart. Less commonly, giant cell arteritis is the cause. The presentation is sudden, painless, monocular vision loss. On exam, the retina looks cloudy, but the fovea stands out as a cherry red spot. Sometimes emboli can even be seen directly, appearing as yellow refractal crystals inside the arterioles. Retinal vein occlusion happens when a retinal vein is blocked by thrombosis. Central retinal vein occlusion involves the main vein, while branch occlusion occurs in arteriovenous crossing, where a hardened artery compresses a vein. On funduscopy, the appearance is dramatic. Retinal hemorrhages, venous engorgement, and edema, often described as a blood and thunder appearance. Retinal detachment is a separation of the neurosensory retina from the underlying retinal pigment epithelium. This cuts off the retina from its blood supply, leading to hypoxia and photoreceptor death. There are two types. Rhegmatogenous detachment, the most common, caused by retinal tears. This is often associated with posterior vitreous detachment, which is more common with age or high myopia. Non-rhegmatogenous detachment, caused by traction or fluid buildup. Symptoms often begin with floaters or flashes of light, followed by painless monocular vision loss. Patients describe it as a dark curtain falling over their vision. On exam, the retina looks opaque and wrinkled, with vessels bending in new directions. This is a surgical emergency. Retinitis pigmentosa is a group of inherited disorders that cause progressive degeneration of photoreceptors and retinal pigment epithelium. Sometimes it's linked with abetalipoproteinemia. The first symptoms are night blindness, or nyctalopia, and peripheral vision loss. On funduscopy, you'll see a triad: pale optic disc, narrowed retinal vessels, and dark, bone spicule-shaped pigment deposits. Retinopathy of prematurity occurs in premature infants who are exposed to high oxygen levels after birth, for example, with treatment for neonatal respiratory distress syndrome. In the womb, the retina develops in a relatively hypoxic environment. Premature babies suddenly lose that environment, and with extra oxygen, vascular growth is arrested. Later, as the retina grows, hypoxia stimulates VEGF, leading to abnormal neovascularization. This can cause tractional retinal detachment and is a common cause of childhood blindness. Finally, retinoblastoma, the most common intraocular malignancy in children. It arises from immature retinal cells and is caused by mutations in both copies of the RB1 tumor suppressor gene on chromosome 13. Normally, RB1 halts cell division at the G1S checkpoint, so losing both copies allows uncontrolled growth. Retinoblastoma can be sporadic or familial due to loss of heterozygosity. It often presents with leukocoria, a white reflection in the pupil, or with strabismus, nystagmus, or eye redness. Here is the visual presentation of the retinal disorder. Okay, the next is papilledema. This is optic disc swelling, and it's usually bilateral. The cause is increased intracranial pressure, like when there's a mass effect in the brain. What's happening is that axoplasmic flow inside the optic nerve gets blocked. On funduscopy, you'll see an elevated optic disc with blur margins. Next is leukocoria. This literally means white pupil. It's the loss of the normal red reflex. When you shine a light into the eye, instead of seeing a healthy red glow, you see a white reflex. In children, the most important causes are retinoblastoma and congenital cataracts. And finally, uveitis. This is inflammation of the uvea, the middle layer of the eye. The specific name depends on the location. If the front part is inflamed, it's called anterior uveitis or iritis. If the back part is inflamed, it's called posterior uveitis, which can include choroiditis or retinitis. Signs can include hypopyon, which is a collection of pus in the anterior chamber, or conjunctival redness. Uveitis is often linked with systemic inflammatory diseases, for example, sarcoidosis, Behçet syndrome, juvenile idiopathic arthritis, or conditions associated with the HLA-B27 gene. Pupillary control. Meiosis. This means constriction, and it's controlled by the parasympathetic system. The first neuron goes from the Edinger-Westphal nucleus to the ciliary ganglion through cranial nerve 3. The second neuron travels in the short ciliary nerves to the sphincter pupillae muscles. An easy way to remember it: short ciliary nerves shorten the pupil diameter. Now, the pupillary light reflex. Light in either retina sends a signal through cranial nerve 2 to the pretectal nuclei in the midbrain. That activation then stimulates both Edinger-Westphal nuclei. As a result, the pupils constrict bilaterally, giving us both the direct reflex and the consensual reflex. The result is that illumination of one eye causes both pupils to constrict. Next is mydriasis, which means dilation, and this one is controlled by the sympathetic system. The first neuron runs from the hypothalamus to the ciliospinal center of Budge, which is located at spinal cord levels C8 to T2. The second neuron exits at T1 and goes up to the superior cervical ganglion, traveling along the cervical sympathetic chain near the lung apex and the subclavian vessels. The third neuron forms a plexus along the internal carotid artery, passes through the cavernous sinus, and enters the orbit as the long ciliary nerve, which goes to the pupillary dilator muscles. Remember, long ciliary nerves make the pupil diameter longer. These sympathetic fibers also innervate the smooth muscles of the eyelids, the minor retractors, and the sweat glands of the forehead and face. Finally, the relative afferent pupillary defect, also called the Marcus gun pupil. This happens when there are unilateral or asymmetric lesions of the afferent limb of the pupillary reflex, such as in the retina or the optic nerve. Normally, when light shines into a normal eye, you get constriction of the ipsilateral eye, that's the direct reflex, and constriction of the contralateral eye, that's the consensual reflex. But when the light is swung from a normal eye to an affected eye, instead of both pupils constricting, they actually dilate. Horner syndrome. Horner syndrome is basically a sympathetic denervation of the face. The classic triad is ptosis, that's a slight drooping of the eyelid because of weakness of the superior tarsal muscle. Meiosis, which is pupil constriction, and anhidrosis, the absence of sweating, along with the absence of flushing on the affected side of the face. It's associated with lesions along the sympathetic chain. The first neuron can be affected by things like a pontine hemorrhage, lateral medullary syndrome, or a spinal cord lesion above T1, for example in Brown-Sequard syndrome or late-stage Syringomyelia. The second neuron can be damaged from stellate ganglion compression, classically by a Pancoast tumor. And the third neuron can be disrupted by a carotid dissection, which is typically painful. In this case, anhidrosis is usually absent. Ocular motility. When it comes to eye movement, Each extraocular muscle has its job. The superior rectus moves the eye upward, the inferior rectus moves it downward, the medial rectus pulls it inward, the lateral rectus pulls it outward, the superior oblique pulls it down and in, and the inferior oblique pulls it up and in. Here's a simple formula to remember the innervation. Cranial nerve 6 innervates the lateral rectus. Cranial nerve 4 innervates the superior oblique, and cranial nerve 3 innervates all the rest. That's why people remember it like LR6, SO4, R3. Arrows in the illustration depict the direction of gaze with which to test each muscle. When testing on muscles, remember, the obliques go opposite. That means the left superior oblique and inferior oblique are tested while the patient is looking to the right, and vice versa. And for the inferior oblique specifically, use the rule IOU. The inferior oblique is tested while the patient looks up. Blowout fracture. A blowout fracture refers to an orbital floor fracture, usually from trauma to the eyeball or the infraorbital rim. The risk here is entrapment of the inferior rectus muscle or orbital fat. This can also cause injury to the infraorbital nerve, leading to sensory changes. Strabismus. Strabismus simply means misalignment of the eyes. People often call it crossed eyes. The most common type in children is esotropia, where the eye deviates toward the nose. Complications can include amblyopia, which is reduced visual acuity due to maldevelopment of the visual cortex, diplopia, or double vision, and even adverse psychosocial effects. Amblyopia, often called lazy eye, usually develops when there's abnormal visual experience early in life, such as for strabismus. It's typically unilateral, meaning it affects one eye. Cranial nerve 3, 4, and 6 palsies. Cranial nerve 3 has both motor and parasympathetic components. The motor fibers are central, and the parasympathetic fibers are peripheral. Let's start with cranial nerve 3 damage. There are several common causes. Ischemia, which produces pupil sparing because the motor fibers are affected more than the parasympathetic fibers. Uncal herniation, which can lead to coma. Posterior communicating artery aneurysm, which produces a sudden onset headache. Cavernous sinus thrombosis, which presents with pertussis and involvement of cranial nerves 4, V1, V2, and 6. And midbrain stroke, which can cause contralateral hemiplegia. The motor output of cranial nerve 3 goes to the extraocular muscles. It's primarily affected by vascular disease, like diabetes mellitus, where glucose is converted to sorbitol. That damages the inside of the nerve because oxygen and nutrients diffuse poorly to the interior. Since the motor fibers are located in the middle of the nerve, they get compromised. The classic signs are ptosis, with a down-and-out gaze. The parasympathetic output runs along the outside of cranial nerve 3, so is the first to be affected by compression, like from a posterior communicating artery aneurysm or an uncal herniation. Here, the signs are a diminished or absent pupillary light reflex, a blown pupil, and often the same down-and-out gaze. Now let's look at cranial nerve 4 damage. This is the trochlear nerve. With a trochlear palsy, the pupil is higher in the affected eye. There's impaired intorsion, and the patient develops a characteristic compensatory head tilt to the contralateral or unaffected side. This tilt helps compensate for the lack of intorsion in the affected eye. Clinically, these patients complain of difficulty going downstairs or reading because they can't see the floor with cranial nerve 4 damage. Finally, cranial nerve 6 damage, which is the abducens nerve. This nerve normally abducts the eye. In a palsy, the affected eye is unable to abduct, so it gets displaced medially in the primary position of gaze. Visual field defects. The ventral optic radiation, also known as Meyer's loop, carries information from the lower retina. It travels through the temporal lobe and loops around the inferior horn of the lateral ventricle. On the other hand, the dorsal optic radiation carries signals from the superior retina and takes a path through the parietal lobe. Now, let's match visual field defects with the corresponding lesions. When the macula is affected, like in macular degeneration, you see a central scotoma. If there's a problem in the optic nerve, you'll see left onopia if it's the left nerve. Damage to the optic chiasm leads to bitemporal hemianopia, which is the loss of the outer visual fields. If the optic tract is affected, you get right homonymous hemianopia, meaning the right visual field is gone in both eyes. When the Meyer loop in the temporal lobe is damaged, it causes a right upper quadrant anopia, also called a pie-in-the-sky defect, and that's from a left temporal lesion. Damage to the dorsal optic radiation in the parietal lobe gives a right lower quadrant anopia, or pie on the floor, again due to a left parietal lesion. Lesions of the visual cortex lead to right homonymous hemianopia with macular sparing, which usually happens in a PCA infarct. A quick note here. When an image hits the primary visual cortex, it's actually upside down and left-right reversed. Pretty neat, right? Now, let's move to the cavernous sinus. This is a collection of venous sinuses sitting on either side of the pituitary gland. Blood from the eye and superficial cortex drains into the cavernous sinus, which then flows to the internal jugular vein. Several important structures pass through here, including cranial nerves 3, 4, 5-1, 5-2, and 6, plus postganglionic sympathetic fibers to the pupil, all en route to the orbit. The cavernous portion of the internal carotid artery is also right there. A handy way to remember the nerves is tomato, internal carotid artery, trochlear nerve, oculomotor nerve, maxillary nerve, abducens nerve, trigeminal nerve, ophthalmic nerve. Cavernous sinus syndrome can happen due to a pituitary tumor causing mass effect, a carotid cavernous fistula, or cavernous sinus thrombosis from infection. Remember, infections can spread here because dural venous sinuses don't have valves. The syndrome presents with variable ophthalmoplegia, like weakness in CN3 and CN6, loss of corneal sensation, Horner syndrome, and sometimes maxillary sensation loss. Internuclear ophthalmoplegia, or INO. To understand this, we need to start with the medial longitudinal fasciculus, or MLF. The MLF is a pair of heavily myelinated tracts that connect the CN6 and CN3 nuclei, coordinating both eyes to move in the same horizontal direction. Because eye movements need to be fast and precise, the MLF is highly myelinated to ensure rapid communication between these nuclei. When there's a lesion in the MLF, it leads to internuclear ophthalmoplegia, a type of conjugate horizontal gaze palsy. What does that mean? Basically, the communication between CN6 and CN3 is broken. So when the CN6 nucleus fires to move the ipsilateral lateral rectus, the contralateral CN3 nucleus doesn't get the signal to contract the medial rectus. The result, the eye on the side of the lesion can't adduct, while the other eye abducts normally, but often with nystagmus as the brain tries to compensate. Lesions can be unilateral or bilateral. Bilateral lesions are classically seen in multiple sclerosis or stroke. One important point, convergence is usually normal because that pathway doesn't depend on the MLF. Here's how it works in action. Imagine a lesion in the right MLF. When you look to the left CN6 nucleus fires, contracting the left lateral rectus and sending a signal through the left MLF to the right CN3 nucleus to contract the right medial rectus. But if the right MLF is damaged, the right medial rectus fails to contract. This is why the directional term, like right INO or left INO, refers to the eye that cannot adduct. So, in a right INO, the right eye fails to adduct while the left eye abducts with nystagmus. The pathway goes like this. The paramedian pontine reticular formation, or PPRF, in the pons activates CN6, which should coordinate with CN3 in the midbrain via the MLF. Damage to the MLF interrupts this signal. Now let's move on to eyelid disorders. First up is preseptal cellulitis. This is an anterior soft tissue infection of the eyelid. Patients usually present with mild symptoms. Think unilateral ocular pain, swelling, and redness, even at rest. It's important to recognize because it's generally less severe than orbital cellulitis, but still needs treatment. Speaking of which, orbital cellulitis is a posterior infection that affects the contents of the orbit, like fat and muscles. Unlike preseptal cellulitis, patients experience pain with eye movement, often double vision or diplopia, and sometimes fever. It's commonly secondary to bacterial sinusitis and carries a risk of vision loss, cavernous sinus thrombosis, and even intracranial spread. The usual culprits are Staphylococcus aureus and streptococci. So if someone has an inflamed, painful, and movement-restricted eye, you always have to think orbital cellulitis and act fast. Next is blepharitis. This is inflammation of the eyelid margin, often causing irritation, crusting, and redness. It can be chronic and annoying, but usually isn't sight-threatening. Hordeolum, or stye, is an acute infection of the sebaceous or sweat glands of the eyelid. Patients usually have a tender, red nodule that can be quite painful. If it persists and becomes non-infectious, it may turn into a chalazion. Chalazion is caused by obstruction of a meibomian or Z's gland, leading to granulomatous inflammation. Unlike a stye, it's typically painless and slow-growing. Finally, there's xanthelasma, which is a yellowish patch on the medial eyelid. While it's mostly cosmetic, it can sometimes be associated with genetic and lifestyle factors, such as high cholesterol. Let's go into neurology pharmacology, specifically anticonvulsant drugs. We'll begin with the narrow-spectrum agents, which are mainly used for focal seizures. First is phenytoin. Its mechanism of action is to block sodium channels. The common adverse effects include sedation, dizziness, diplopia, which means double vision, gingival hypertrophy, which is gum enlargement and can be prevented with folate supplementation, skin rash, excessive hair growth known as hirsutism, and drug interactions due to induction of the cytochrome P450 enzyme system. The rare but serious adverse effects are Stevens-Johnson syndrome, drug reaction with eosinophilia, and systemic symptoms also called DRESS, liver toxicity or hepatotoxicity, peripheral neuropathy, osteoporosis, folate depletion, and teratogenicity, meaning it can cause birth defects. Next is carbamazepine, which also works by blocking sodium channels. The common adverse effects are sedation, dizziness, double vision, vomiting, diarrhea, syndrome of inappropriate antidiuretic hormone secretion, also called SIADH, skin rash, and drug interactions through cytochrome P450 induction. Rare but serious adverse effects include Stevens-Johnson syndrome, drug reaction with eosinophilia, and systemic symptoms, hepatotoxicity, agranulocytosis, which is dangerously low white blood cell count, aplastic anemia, which is bone marrow failure, folate depletion, and teratogenicity. Now let's discuss the gabapentinoids, which include gabapentin and pregabalin. Their mechanism is to block calcium channels. The common adverse effects are sedation, dizziness, loss of coordination known as ataxia, and weight gain. For absent seizures, the classic drug is ethosuximide. It works by blocking calcium channels. Common adverse effects are sedation, dizziness, and vomiting. Next, we have the broad-spectrum anticonvulsants, which are effective in both focal seizures and generalized seizures. First among them is valproate. Its mechanisms are multiple. It blocks sodium channels, blocks calcium channels, and inhibits the enzyme gamma-aminobutyric acid transaminase, also called GABA transaminase. Common adverse effects include sedation, dizziness, vomiting, weight gain, hair loss, easy bruising, and drug interactions through inhibition of the cytochrome P450 system. Rare but very important adverse effects are hepatotoxicity, meaning liver failure, pancreatitis, meaning inflammation of the pancreas, and teratogenicity, with valproate being the highest risk anticonvulsant for causing birth defects. Next is lamotrigine, which acts by blocking sodium channels. Common adverse effects are sedation, dizziness, and skin rash. Rare but serious effects include Stevens-Johnson syndrome and drug reaction with eosinophilia and systemic symptoms. Another broad-spectrum agent is levetiracetam. It acts by blocking synaptic vesicle protein 2E, also known as SV2A. Common adverse effects are sedation, dizziness, and fatigue. Rare but serious effects are neuropsychiatric disturbances, such as agitation, irritability, or psychosis. Finally, topiramate. Its mechanisms are blocking sodium channels and potentiating the gamma-aminobutyric acid A receptor, also called the GABA-A receptor. The common adverse effects include sedation, dizziness, mood disturbances such as depression, weight loss, and abnormal sensations known as paresthesia. Rare but important effects are kidney stones and angle closure glaucoma. And that concludes our structured review of anticonvulsant medications, their mechanisms of action, common adverse effects, and rare but serious toxicities. On the next page, there is the presentation of the anticonvulsants, which shows how these drugs works. Barbiturates. Examples include phenobarbital and pentobarbital. The mechanism of action is to facilitate gamma-aminobutyric acid A, or GABA-A, receptor action by increasing the duration of chloride channel opening. This decreases the firing of neurons. A memory aid is barbiturates increase the duration. The clinical uses are as a sedative for anxiety, seizures, insomnia, and alcohol or sedative withdrawal. The adverse effects are significant. Respiratory depression, cardiovascular depression, which can be fatal, central nervous system depression, which is worsened by alcohol, physical dependence, and drug interactions due to induction of cytochrome P450 enzymes. They are contraindicated in porphyria. For barbiturate overdose, treatment is supportive only. Assist with respiration and maintain blood pressure. Benzodiazepines. Examples are diazepam, lorazepam, triazolam, temazepam, oxazepam, midazolam, chlordiazepoxide, and alprazolam. The mechanism of action is to facilitate gamma-aminobutyric acid A action by increasing the frequency of chloride channel opening. A memory tip is benzodiazepines increase frequency. Think frenzodiazepines frequency. They decrease rapid eye movement or REM sleep. Most benzodiazepines have long half-lives and active metabolites, except for the short-acting ones: alprazolam, triazolam, oxazepam, and midazolam. A way to remember them is ATOM. These short-acting agents have a higher addictive potential. The clinical uses of benzodiazepines are wide-ranging. Anxiety disorders, panic disorder, spasticity, status epilepticus using lorazepam, diazepam, or midazolam. Eclampsia, medically supervised withdrawal, for example alcohol withdrawal and delirium tremens, where long-acting chlordiazepoxide and diazepam are preferred. Parasomnias like night terrors and sleepwalking, since they reduce stage N3 and rapid eye movement sleep. As a general anesthetic, providing amnesia and muscle relaxation. As a hypnotic for insomnia. There are some special notes. Lorazepam, oxazepam, and temazepam can be safely used in patients with liver disease and in those who consume a lot of alcohol, because they undergo minimal first-pass metabolism. The adverse effects of benzodiazepines include dependence, additive central nervous system depression when combined with alcohol or barbiturates, since they all bind the gamma-aminobutyric acid A receptor. They have less risk of respiratory depression and coma compared to barbiturates. In cases of benzodiazepine overdose, treatment is with flumazenil, which is a competitive antagonist at the gamma-aminobutyric acid benzodiazepine receptor. But beware, flumazenil can precipitate seizures due to acute benzodiazepine withdrawal. Insomnia therapy. Non-benzodiazepine hypnotics. Examples are zolpidem, Zaleplon, and esopiclone. The mechanism is that they act via the BZ1 subtype of the gamma-aminobutyric acid receptor. The adverse effects include loss of coordination, also called ataxia, headaches, and confusion. Some important notes. They cause only modest next-day psychomotor depression and fewer memory problems compared with older sedative hypnotics. A memory tip. These ZZZ drugs put you to sleep. They have a short duration because of rapid metabolism by liver enzymes. Their effects can be reversed by flumazenil. They carry a lower dependency risk and cause less disturbance of the sleep cycle compared with benzodiazepine hypnotics. Suvorexant. This is an orexin receptor, also called hypocretin receptor antagonist. The adverse effects include central nervous system depression with drowsiness or somnolence, headaches, and abnormal sleep-related activities. It is contraindicated in patients with narcolepsy and in those taking strong CYP3A4 inhibitors. It is not recommended in patients with liver disease. It carries a limited risk of dependency. Ramelteon. This is a melatonin receptor agonist. It binds to MT1 and MT2 receptors in the suprachiasmatic nucleus of the hypothalamus. The adverse effects include dizziness, nausea, fatigue, and headaches. Importantly, it has no known risk of dependency. Triptans. An example is sumatriptan. The mechanism of action is as a serotonin 5-hydroxytryptamine 1B and 1D receptor agonist. They work by inhibiting trigeminal nerve activation, preventing release of vasoactive peptides, and inducing vasoconstriction. The clinical use is for acute migraine attacks and cluster headache attacks. A memory tip. Imagine a sumo wrestler tripping and falling on their head. The adverse effects are coronary vasospasm, which means they are contraindicated in patients with coronary artery disease or vasospastic angina, mild abnormal sensations called paresthesias, and serotonin syndrome if combined with other serotonin agonists. Let's discuss therapy for Parkinson's disease. The most effective treatments are non-ergot dopamine agonists, which are preferred in younger patients, and levodopa combined with carbidopa, which is preferred in older patients. In advanced disease, deep brain stimulation of the subthalamic nucleus or the globus pallidus internus can also be helpful. Dopamine agonists. The non-ergot dopamine agonists, which are the preferred agents, include pramipexole and ropinirole. The toxicities of these drugs include nausea, impulse control disorders such as pathological gambling, postural hypotension, hallucinations, confusion, excessive sleepiness, and edema. The ergot dopamine agonist is bromocriptine, but this is rarely used because of its higher toxicity. Increasing dopamine availability. One agent is amantadine, which increases dopamine release and decreases dopamine reuptake. It is mainly used to reduce levodopa-induced dyskinesias. Toxicities include peripheral edema, livedo reticularis, which is a mottled skin discoloration, and ataxia. Increasing L-dopa availability. Now, let's talk about L-dopa, also called levodopa. The strategy here is to prevent peripheral degradation of L-dopa before it crosses the blood-brain barrier. This way, more L-dopa enters the central nervous system, where it can be converted into dopamine. Levodopa with carbidopa. Carbidopa blocks peripheral conversion of L-dopa into dopamine by inhibiting the enzyme dopa decarboxylase. This also reduces the adverse effects of peripheral dopamine, such as nausea and vomiting. Entacapone and talcapone. These prevent peripheral degradation of L-dopa into 3-O-methyl-dopa, or 3-OMD, by inhibiting the enzyme catecholmethyltransferase, also called COMT. They're used together with levodopa, preventing breakdown of dopamine in the brain. Agents can act centrally, after crossing the blood-brain barrier, to inhibit breakdown of dopamine. Selegiline and razagiline. These block conversion of dopamine into dihydroxyphenylacetic acid, or DOPAC, by selectively inhibiting monoamine oxidase type B, or MAOB. MAOB is more common in the brain than in the periphery. These agents improve symptoms in patients who have cyclic fluctuations in levodopa efficacy, also known as the on-off phenomenon. Talcapone. This agent crosses the blood-brain barrier and blocks conversion of dopamine into 3-methoxytyramine, or 3 metric tons, by inhibiting central COMT. A way to remember this is talcapone pays the toll to cross the blood-brain barrier. Curbing excess cholinergic activity. Antimuscarinic agents can also be used. Examples are benztropine and trihexyphenidyl. They improve tremor and rigidity, but they have little effect on bradykinesia in Parkinson's disease. A memory trick is try parking my Mercedes-Benz. Summary of drug classes. Dopa decarboxylase inhibitor, carbidopa. COMT inhibitors in the periphery, entacapone and talcapone. COMT inhibitor in the brain, talcapone. Amylotype B inhibitors, selegiline and razagiline. Dopamine agonists, pramipexole and ropinirole, which are non-ergot, and bromocriptine, which is ergot. Dopamine availability enhancers, amantadine. Antimuscarinics for tremor and rigidity, benztropine and trihexyphenidyl. Carbidopa with levodopa. Dopamine cannot cross the blood-brain barrier. Levodopa, however, can. Once in the central nervous system, levodopa is converted to dopamine by dopa decarboxylase. Carbidopa is a peripheral dopa decarboxylase inhibitor that does not cross the blood-brain barrier. When combined with levodopa, it increases the bioavailability of levodopa in the brain and reduces peripheral side effects. Clinical use: Parkinson's disease. Adverse effects: nausea, hallucinations, and postural hypotension. With disease progression, therapy can lead to the on-off phenomenon, with improved mobility during on periods and impaired motor function during off periods when patient responds poorly to levodopa or medication wears off. Neurodegenerative disease therapy. Alzheimer's disease. Donepezil, rivastigmine, and galantamine are acetylcholinesterase inhibitors and are first-line treatment. Adverse effects include nausea, dizziness, and insomnia. They are contraindicated in cardiac conduction abnormalities. Memory aid. Donariva forgot-the-gala. Memantine is an N-methyl diaspartate receptor antagonist that prevents excitotoxicity mediated by calcium influx. It is used in moderate to advanced dementia. Adverse effects include dizziness, confusion, and hallucinations. Amyotrophic lateral sclerosis. Riluzole decreases glutamate excitotoxicity and prolongs survival. Memory aid. Treat Lou Gehrig disease with riluzole. Huntington disease. Deutetrabenazine and tetrabenazine inhibit the vesicular monoamine transporter, decreasing dopamine packaging and release. They are used for Huntington chorea and tardive dyskinesia. Let's move on to local anesthetics. Local anesthetics are divided into esters and amides. The esters include benzocaine, chloroprocaine, cocaine, and tetracaine. The amides include bupivacaine, lidocaine, mepivacaine, prilocaine, and ropivacaine. A useful tip: amides have two eyes in their names. Mechanism of action. Local anesthetics block neurotransmission by binding to voltage-gated sodium channels on the inner portion of the channel along nerve fibers. They are most effective in rapidly firing neurons. The chemistry works like this. Tertiary amine local anesthetics penetrate the axonal membrane in their uncharged form. Once inside the cell, they convert into the charged form and then bind to the ion channels. They can be given with vasoconstrictors, usually epinephrine, to prolong the duration of action by decreasing systemic absorption. In infected tissue, which is acidic, alkaline anesthetics become charged and cannot penetrate the membrane effectively. This means that a higher dose of anesthetic is required. The order of sensation loss with local anesthetics is as follows: 1. Pain. 2. Temperature. 3. Touch. 4. Pressure. Clinical use. They are used for minor surgical procedures and for spinal anesthesia. If a patient is allergic to esters, give an amide. Adverse effects. They may cause central nervous system excitation, severe cardiovascular toxicity with bupivacaine, hypertension or hypotension, arrhythmias with cocaine, and methemoglobinemia with benzocaine and prilocaine. Now, let's move to general anesthetics. For a central nervous system drug to act as a general anesthetic, it must either be lipid-soluble in order to cross the blood-brain barrier or be actively transported. The solubility of the drug affects induction and potency. Drugs with low solubility in blood, such as nitrous oxide, have rapid induction and recovery times. Drugs with high solubility in lipids, such as isoflurane, are more potent. MAC, or minimum alveolar concentration, is defined as the concentration of inhaled anesthetic required to prevent 50% of subject from moving in response to a noxious stimulus, such as a skin incision. Potency is inversely related to MAC, meaning that potency equals 1 divided by MAC. Inhaled anesthetics. Examples include sevoflurane, desflurane, and isoflurane. Mechanism. Their exact mechanism of action is unknown. Adverse effects and notes. They cause respiratory depression, suppression of the cough reflex, myocardial depression, and changes in blood pressure. They increase cerebral blood flow, which can lead to increased intracranial pressure. They decrease metabolic rate, as well as skeletal and smooth muscle tone. They may also cause postoperative nausea and vomiting. A dangerous complication of inhaled anesthetics is malignant hyperthermia. Nitrous oxide, or N2O, is another inhaled anesthetic. It can diffuse into and expand gas-filled cavities, such as in pneumothorax. It has very low potency. Intravenous anesthetics. There are several important intravenous anesthetic agents. Propofol. It potentiates the gamma-aminobutyric acid A receptor and inhibits the N-methyl D-aspartate receptor. Adverse effects include respiratory depression and decreased blood pressure. It is the most commonly used intravenous agent for induction of anesthesia. Etomidate. It potentiates the gamma-aminobutyric acid A receptor. Adverse effects include acute adrenal insufficiency and postoperative nausea and vomiting. It is considered hemodynamically neutral, meaning it has minimal effects on blood pressure and heart function. Ketamine. It inhibits the N-methyl D-aspartate receptor. It has sympathomimetic effects, including increased blood pressure, increased heart rate, increased cerebral blood flow, and bronchodilation. Psychotomimetic effects include hallucinations and vivid dreams. Neuromuscular blocking drugs. Neuromuscular blocking drugs are used to produce muscle paralysis in surgical procedures or during mechanical ventilation. They are selective for the N-sub-M nicotinic receptors located at the neuromuscular junction, but they do not act on the N-sub-N nicotinic receptors in the autonomic nervous system. Depolarizing neuromuscular blocking drugs. The classic depolarizing agent is succinylcholine. It is a strong N sub M nicotinic receptor agonist. Succinylcholine produces sustained depolarization of the neuromuscular junction and prevents further muscle contraction. The reversal of blockade depends on the phase. Phase 1 blockade. This is prolonged depolarization. There is no antidote at this stage. In fact, the blockade is potentiated if cholinesterase inhibitors are administered. Phase 2 blockade. At this point, the membrane has repolarized and the N sub M nicotinic receptors are available, but they have become desensitized. The blockade at this phase may be reversed with cholinesterase inhibitors. Complications of succinylcholine use include hypercalcemia, hyperkalemia, and malignant hyperthermia. There is also an increased risk of prolonged muscle paralysis in patients with pseudocholinesterase deficiency, since they cannot efficiently metabolize succinylcholine. Non-depolarizing neuromuscular blocking drugs. Examples include atracurium, cisatracurium, pancuronium, rocuronium, and vecuronium. These agents act as competitive antagonists of the N sub M nicotinic receptor at the neuromuscular junction. Reversal of blockade is possible. This can be achieved with sugammadex or cholinesterase inhibitors, such as neostigmine. However, when cholinesterase inhibitors are used, they also increase acetylcholine at muscarinic receptors, which can lead to bradycardia. To prevent these muscarinic side effects, anticholinergic drugs, such as atropine or glycopyrrolate, are given alongside. Malignant hyperthermia. Malignant hyperthermia is a rare but life-threatening hypermetabolic condition. It is triggered by the administration of potent inhaled anesthetics, such as sevoflurane, desflurane, and isoflurane, or by succinylcholine, in susceptible individuals. The susceptibility is due to either de novo mutations or inherited autosomal dominant mutations in the ryanodine receptor type 1, or YR1, or in dihydropyridine receptors, DHPR. The underlying mechanism is excessive calcium release from the sarcoplasmic reticulum, leading to sustained muscle contraction, hypercapnia, tachycardia, masseter or generalized muscle rigidity, rhabdomyolysis, and hyperthermia. The treatment of malignant hyperthermia is dantrolene, which is a ryanodine receptor antagonist. Skeletal muscle relaxants. Skeletal muscle relaxants are used to reduce muscle spasticity and spasms in a variety of conditions. The first drug is baclofen. Baclofen acts as a gamma-aminobutyric acid type B receptor agonist in the spinal cord. It is used in the treatment of muscle spasticity, dystonia, and multiple sclerosis. You can remember it as acting on the back, meaning the spinal cord. A common side effect is sedation. The second drug is cyclobenzaprine. Cyclobenzaprine acts within the central nervous system, mainly at the brainstem. It is used for muscle spasms. This drug is structurally related to tricyclic antidepressants, and therefore it may cause anticholinergic adverse effects such as dry mouth, urinary retention, and blurry vision, as well as sedation. The third drug is dantrolene. It prevents the release of calcium from the sarcoplasmic reticulum of skeletal muscle by inhibiting the ryanodine receptor. Clinically, it is used to treat malignant hyperthermia, which can occur as a complication of inhaled anesthetics or succinylcholine, and neuroleptic malignant syndrome, which is a toxicity of antipsychotic drugs. Dantrolene acts directly on the skeletal muscle. The fourth drug is tizanidine. Tizanidine is an alpha-2 adrenergic receptor agonist that acts centrally. It is used for muscle spasticity in conditions such as multiple sclerosis, amyotrophic lateral sclerosis, also known as ALS, and cerebral palsy. Opioid analgesics. Opioid analgesics work by acting as agonists at opioid receptors. There are three main receptor types: the mu receptor, which is associated with beta-endorphin, the delta receptor, which is associated with enkephalin, and the kappa receptor, which is associated with dynorphin. When opioids bind to these receptors, they modulate synaptic transmission. They close presynaptic calcium channels and open postsynaptic potassium channels. This decreases synaptic transmission and inhibits the release of several neurotransmitters, including acetylcholine, norepinephrine, serotonin, glutamate, and substance P. Opioids differ in their efficacy. Full agonists include morphine, meperidine, methadone, codeine, and fentanyl. Codeine is actually a prodrug, requiring activation by the enzyme CYP2D6. Partial agonists include buprenorphine. Mixed agonist and antagonist drugs include butorphanol and nalbuphine. Pure antagonists include naloxone, naltrexone, and methylnaltrexone. In terms of clinical use, opioids are prescribed for moderate to severe pain or for refractory pain that does not respond to other medications. They are also used in diarrhea, for example with loperamide and diphenoxylate. Other uses include acute pulmonary edema and maintenance programs for opioid use disorder, using drugs like methadone or a combination of buprenorphine with naloxone. They are also used for neonatal abstinence syndrome, where methadone or morphine may be given. Adverse effects of opioids include nausea and vomiting, pruritus due to histamine release, opioid use disorder due to the potential for dependence, respiratory depression, which is the most dangerous complication, constipation and spasm of the sphincter of Oddi, meiosis or pinpoint pupils, which is a classic feature of opioid intoxication. Interestingly, the one exception is meperidine, which can cause mydriasis or pupil dilation. Opioids also cause additive central nervous system depression when combined with other sedating drugs. It is important to note that tolerance develops to many of these adverse effects, but tolerance does not develop to meiosis or constipation. Opioid toxicity can be treated with naloxone, a competitive opioid receptor antagonist. For long-term relapse prevention in detoxified patients, naltrexone can be used. Tramadol. Finally, let's talk about tramadol. Tramadol is a very weak opioid receptor agonist, but it also inhibits the reuptake of norepinephrine and serotonin. It is used mainly for the treatment of chronic pain. Its adverse effects are similar to those of opioids, but tramadol also has additional risks. It lowers the seizure threshold, increasing the risk of seizures. It can also cause serotonin syndrome, especially if combined with other serotonergic drugs. Butorphanol and nalbuphine. These are mu-opioid receptor partial agonists and kappa-opioid receptor full agonists. They're used for analgesia in severe pain, such as during labor. A key point to remember is that mixed opioid agonists and antagonists, like butorphanol and nalbuphine, cause less respiratory depression compared with full opioid agonists. However, they can precipitate opioid withdrawal symptoms if a patient is also taking a full opioid agonist. This happens because they compete for the same opioid receptors, displacing the full agonist. Another important note is that their effects are not easily reversed with naloxone, since naloxone competes primarily with full agonists at the mu receptor. Now, let's move on to capsaicin. Capsaicin is a natural compound found in hot peppers. Its mechanism involves excessive stimulation and subsequent desensitization of nociceptive nerve fibers, which leads to depletion of substance P, the neurotransmitter responsible for transmitting pain signals. As a result, capsaicin reduces pain sensation. Clinically, it is used for musculoskeletal pain and neuropathic pain. Next, let's talk about glaucoma therapy. The goal of glaucoma treatment is to reduce intraocular pressure, or IOP, by either decreasing the amount of aqueous humor produced or by increasing aqueous humor drainage. Remember this phrase, beta D humor may not be politically correct. It helps recall that beta blockers decrease humor. Let's go drug class by drug class. 1. Beta blockers, such as timolol, betaxolol, and cartiolol. Their mechanism is to decrease aqueous humor synthesis. They do not cause any changes in pupil size or vision. 2. Alpha agonists. Epinephrine, which is an alpha-1 agonist, decreases aqueous humor synthesis via vasoconstriction. Apraclonidine and brimonidine, which are alpha-2 agonists, decrease aqueous humor synthesis as well, and they also increase outflow via the uveoscleral pathway. Adverse effects include mydriasis with alpha-1 agonists, which means they should not be used in closed-angle glaucoma. Alpha-2 agonists can cause blurry vision, ocular hyperemia, foreign body sensation, allergic reactions, and ocular itching. 3. Diuretics, particularly acetazolamide. This works by decreasing aqueous humor synthesis through inhibition of the enzyme carbonic anhydrase. It does not cause any pupillary or vision changes. 4. Prostaglandin analogs, such as bimatoprost and latanoprost, which are analogs of prostaglandin F2 alpha. They increase the outflow of aqueous humor by decreasing resistance through the uveoscleral pathway. Adverse effects include darkening of the iris, often leading to brown discoloration and eyelash growth. 5. Cholinomimetics, which act via muscarinic M3 receptors. These can be direct agonists like pilocarpine and carbachol, or indirect agonists such as physostigmine and ecothiopate. Their mechanism is to increase outflow of aqueous humor by causing contraction of the ciliary muscle, which opens the trabecular meshwork and allows drainage into the canal of Schlemm. Pilocarpine is especially useful in acute angle closure glaucoma because it is very effective at rapidly opening the meshwork. The adverse effects include miosis, which is contraction of the pupillary sphincter muscles, and cyclospasm, which is contraction of the ciliary muscle.